So, as Julie was saying, in your packet is two different sheets for you. This is just the, if I can pull it off, this is just the PowerPoint that you can follow along with if you want. Probably the bigger thing, though, is this documentation. This is actually since May of last year. These are the latest drugs that have been approved by the FDA. They're drugs and biologicals. The reason that's kind of important is you can kind of notice there's a lot of drugs. So obviously we're not going through all these drugs today, but I wanted to give you a highlight of a couple of the big hitting ones that will have probably an impact on practice depending on which practice you use. Some of them are really more applicable to the hospital setting versus some in the retail. On the very back of this sheet is an information thing. It's an information sheet. Matter of fact, the first part of this discussion is basically showing you how to find the information I found. I'm a big advocate for not just feeding people one day, but actually teaching them how to fish, especially fish for information about drugs. So this is actually going to be very helpful to you. And this is, if I were to save anything from my talk, it'd be this one sheet right there in the very back. Okay, because everything else changes. For example, just on this presentation that I made, I literally turned it in the morning yesterday. I mean, that's about as close as you can cut it. And then I run into Steve over here, and Steve said, "Hey, did you hear about this drug that just got approved?" And I'm like, "Are you kidding me?" We'll discuss that drug in a little bit here, but that's what I'm talking about whenever drug information is severely dynamic in nature. So I'm pretty flexible on exactly what's going on. I'm more interested in application and how big of an impact it's going to have on different practices than necessarily the nuances of each and every drug. We'll go over some of the highlights of these drugs. Does that mean I'm an expert? No. Let's put that down right now. I am not an expert in nuance on these drugs. I do know about them, can explain some stuff to you, big trials that are along with this, and hopefully that'll help you to kind of read a little bit more if you're interested in that particular drug. A couple of things as we go along. You'll see priority review and things of that sort. We'll go over that in a little bit. And I've classified this down into different sections of practice. So that should hopefully help you as well in determining whether you want to contain or maintain this information or not. Okay, so you've got that sheet. Let's go ahead and go into the PowerPoint then. So of course, this is a new drug update. Everybody loves the new drug update, but I will admit I'm not as particularly fond of the new drug update, even though I'm a drug information specialist, only because to me it seems like a moving target, and that at any given moment it's going to change. But that's fine. It is definitely something many pharmacists ask for because they want to learn about it, and that's good. So again, we'll hit the highlights. So medical information is never just one location. If you get anything out of this today, again, this is probably one of the big things. All knowledge, wisdom, resources must be brought together to develop a plan of elegance and practicality. Probably one of the big things you want to teach your students is it's not all sitting in lexicon. Please stop looking in just lexicon. There's so many other resources out there that are much better to answer the question. That's why they call it practice and not just, reading out of a book. It's so much more. It's so much more, and these students need to be taught that what we do is more than reading the information out of lexicon. Its application is changing based on not only the guidelines, which are a good starting spot, but also based on the needs of that particular patient and what's going on with them currently. It might be drug interactions, it might be concomitant disease processes. All of that takes into account what you're going to do for your patient. That's a hard concept for students because they do like black and white. And they need to learn shades of gray, especially from you, whenever you teach them in the practice. Okay, so I have no conflict of interest. within any of this discussion, I use all this information and I pick up any new resource I can at any given point in time that will be helpful to practice. So objectives, we're going to distinguish areas within the FDA where medications are updated. We're going to explain some mechanisms of action and where new agents are being used. We'll describe the difference between bioequivalent and biosimilar. We will be discussing some laws and policies today. Identify which new agents are specialty and or REMS drugs. We'll get into that specifically in a moment here. Okay, so just as an FYI, there's over 95,000 drugs on the market. Now, these are just the ones that have the NDC number. This does not include those that are made on the street, those that happen to show up in the grocery store for a few bits of time and aren't registered in any way, shape, or form. So 95,000, that probably should be a big point right there that no, you can't remember at all. A fair portion of this is homeopathic agents. Much of it's unapproved drugs. You might have heard them called DESI drugs, and we'll get into that in a minute. But there's just a whole host of different agents. That being said, we aren't going to find everything in Drugs at FDA. Drugs at FDA happens to be the website that the FDA has that's for all drugs that are FDA approved, that are on the market, okay? All drugs. That does not, however, include biologicals. They have another section for that. So as for new agents that just came out since May, we've got over 10,000 drugs that have been approved. And as for unapproved, we've got about 1,100. So you can see, obviously you can't remember it all, but you need to know how to get there. Of those, we've got 605 drugs that are regular drugs, and of course, got some gases that nobody really would work with much here. And homeopathic, that would be retail, if you sell any homeopathic agents in the retail setting. Okay, so here are the 11 major classifications of drugs and where to find the information. And we're going to go through each and every one of these, again, to teach you how to fish. And the biggest one is going to be that FDA approved and the FDA approved biologicals. Okay, so these again are quick resources for different agents. So the first one, again, this is where we'll be at mostly. FDA approved drugs includes OTCs, prescriptions of course, agents that are REMS agents. Do you guys know what REMS means? What's REMS mean? Everybody does it. You just may not realize you do it. So what's REMS? Yeah, you get stuck with it with me. So literally, the retail pharmacy is beautiful at actually integrating REMS into their computer system. It's very clean cut. You guys have done an excellent job. In the hospital setting, we stink at it. We're not good at integrating it into our computer system. Plus, the laws and the rules regarding REMS within the hospital setting are pretty much a hit or miss, because most of the REMS, what are called ETASUs, which basically are how you would get that drug to the patient. Does, the physician have to be registered? Does the patient have to be registered? Things of that sort. All of those usually are more focused on the retail setting. Every once in a while you run into one that actually is for more the hospital setting. As for specialty agents, we now even have specialty pharmacies out there. Why do we have them? Because they make a lot of money. And that's the truth of it. So CMC has the regular inpatient pharmacy and outpatient pharmacy. They do okay. They do fine. But across the street in the in the cancer center is what's called a specialty pharmacy on the first floor. So they deal not only in agents that are used in addition to chemotherapy, but they might deal in other injectables, monoclonal antibodies in particular, and all of those have to go through oftentimes pre-approval. Okay, so see many of these drugs that are under specialty evaluation, the patient can't readily get it to them, even though it might be like first line. Like for example, Humira's just recently become first line for some of the immunological problems. Okay, as for orphan drugs, we do have orphan drug designation that's within the FDA, but of course that's beyond the scope of this discussion. You may, however, be asked to do it on a rare occasion for a particular patient just happens to be going to your pharmacy or to your hospital. Biological and biosimilars, we got some great good news for everybody, especially in this state. Biologicals is pretty much your monoclonals, could be your blood products. It could be a whole host of different agents. In the FDA approved area or the drugs at FDA, we're talking more along the lines of monoclonal antibodies. That's probably the biggest section. And then, of course, we're going to get into biosimilar here in a second. By the way, that's purple book. Do you guys remember all the different colors of the books? We'll actually go over that. It's a NAPLEX question. Go figure. So let's talk about biosimilar. Biosimilar, we're talking about now the new generics, for lack of better wording, to the biological. So now Humira has a generic, I think Remicade has a generic, and you can't really call them generics because they aren't necessarily they aren't equivalent with regards to their kinetics and that. And even they have some minutia differences on how they're made. But they still do the exact same thing as what the mother product does, okay? Yet they're still, because they're not bioequivalent and they're biological entities, there had to be new rules made up about this. So now you see within the system biosimilars, okay? And without state rules, you pretty much can't do an automatic substitution, okay? However, in this state, they were lagging a little bit behind. There are a number of states that were proactive on this when they heard the biosimilars coming out. We, however, were not necessarily proactive, but that will soon be fixed. On June 8th of 2018, we will be able to substitute our biosimilars for our biological agents. So this is in House Bill 4524, and we're talking about Section 3512B. And in order for this to occur, you can do a substitution, and the practitioner, the prescribing practitioner, has to have basically said it's okay to substitute in writing. The pharmacist has to inform the customer that that's what you're going to do, so you're not going to get your Humira anymore. Your insurance company wants you to get this instead. And that's also another FYI. Insurance companies have been lagging as well on biologicals and biosimilars. So some companies say, yeah, go ahead and sub. Other companies say, no, we want to stick with the original. So it's really dependent on the insurance company. And it's probably best to write it that way. So whichever's to the benefit of the patient. You're going to ask a question in the back? No? Okay. The pharmacist does have to notify the physician of the substitution within 10 days, just kind of an FYI. So that's June 8th for everybody. Across the board, you are going to want to know that. Already at CMC, we do basically a therapeutic interchange, but obviously you can't do that in the retail. So non-FDA approved for market drugs. These are also prescriptions and OTCs. They change all the time. As a matter of fact, that used to be what most drugs were unapproved for market, because if you remember in your pharmacy history 10 zillion years ago, what was the first restriction they put on drugs? And this had to do with like children dying from opioid overdose, people kind of misbranding things. Do you remember all that stuff that you learned in history? Well, that's the problem. So when you brought a drug out onto market, it had to be FDA approved and proven to be safe. That's all it had to prove. It didn't say efficacious, it said safe, okay? Obviously, the FDA said, well, that's not good enough. So they said, you've got to show that they actually have efficacy. A lot of companies still haven't done that. And they were supposed to have everything done by 2005. Most companies did not do anything. Why? Because the FDA gave them 20 years to get their act together, and they still didn't do it. What was the FDA going to do? Kick them off? You know, whoever would kick off vasopressin from the market, that wouldn't happen. Well, it did. Okay, so there were many drugs, and there are still many drugs that are going on that are called DESI drugs, old-timey drugs. For example, the one I like to express the most is phenobarbital, also known, you can have it in Donatol. How many people have used Donatol in their patients? Yeah, a lot of people. Guess what? It won't be around much longer. Why? Because nobody's bothered to prove that Donatol works. Matter of fact, there's literature to prove it doesn't. And the other thing with the phenobarbital for seizures, nobody set out to prove that either. So that's a real problem, especially in the neonatal area. We are seeing a lot of drugs getting wiped out. So the FDA went after those DESI drugs that were very unsafe. Okay, they, in one day, I remember a couple of years, well, it's more than a couple of years ago, they wiped out in one day 250 over-the-counter cough and cold medications. They all just went off the shelf. And when you looked around the pharmacies, there was nothing sitting there because they were all the big hits. Okay. Another day, I remember fighting about this with the higher-ups about Darvocet. Anybody remember Darvocet? Oh, yeah. Darvocet was going off the shelf like water. I mean, every little old lady wanted their pink pill, and it had to be pink. And fluorescent pink meant it was better. Yeah. God only knows why it had to be pink. But nonetheless, even though the literature supported the fact that it wasn't any better than Tylenol, everybody wanted their pink pill. Okay, and it carried a lot of problems with it. It had a ceiling as to how effective it was. There was actually significant toxicity along with it. And finally, the FDA came out and said, and this was a really unique ruling, fine if you use it, but hey, pharmacist, you're liable. Physician, you're liable. Drug company's not liable. You're liable as a practitioner for dispensing that to your patient, just fair warning, because it does cause cardiovascular death in some cases. All of a sudden, in one day, the U.S. wiped out all their Darvocet off the shelves. I was singing praises because I've been trying to get it off my shelf for years. So the DESI drugs are definitely kind of that mix. And they're just regular drugs that we've used for years, and people just don't realize they're not FDA approved. FDA approved for marketing. Does that make sense to you? That means they have no official indication that the FDA agrees to. Okay. So you'll see those go by the wayside here pretty quick. The list has definitely gone down quite a bit. Where do you find information about this? This is through the National Drug Code. Everybody has a National Drug Code. The NDC database actually keeps all 95,000 agents there where you can find the unapproved drugs, as well as homeopathics and everything else. Okay. Don't forget your furry friends. We do have animal drugs out there. We being pharmacists, we have a tendency, of course, to focus on just human drugs, but there are animal drugs out there too that are very specific, and they carry a very nice formulary in what's called the Green Book, which is also on the FDA website. If you go there, it'll talk about dosing and everything, when you can use it on an animal, when you can't, what type of animal you can use it on, and also what utility the animal holds. For example, if you have a cow can hold several different types of utility. So it might just be a pet. I don't know why anybody would have it for a pet, but surely it could be a pet. It might be used for milking. Okay, so that would be another term. So now you've got a restriction on antibiotics that you're allowed to use, hormones and antibiotics. It could be used for meat. That's even greater restrictions. How long does the drug stay in the body? So actually, the rules are even more strict in the animal setting than they are in the human. We just don't realize it because we have to determine what way we are using that animal first, okay, to determine how we're going to, what drugs are appropriate. Just as an FYI, if you ever want to know, Merck Manual actually has a veterinary manual out. It's totally free, and they keep it updated all the time, so if you're at a loss as to what to do, that's a great place to go. But fair warning, you as a pharmacist, if you've not been officially trained as a veterinary pharmacist, you're not allowed to make a recommendation about FIFI. You can talk about drugs, but you can't talk about specifically FIFI. FIFI's got to be talked about by the vet. Does that make sense? Yeah.
Is there like a specialization or certification?
Yep, absolutely. So there are, I think there's only maybe 3 or 4 veterinary pharmacy programs in the United States. One I know of is up in Ohio. I think there's one in, Virginia? Yeah. And a lot of schools, they'll do kind of like an elective on it, but it's not to the level that's required. These individuals are usually doing residencies that are, 1 or 2 years long, usually 2 years. and they're highly specialized in the area. You might see some of the compounding pharmacies especially get into that because, you know, they're going to try to make their money based on those unique situations. Okay, foreign drugs. Obviously, West Virginia, we don't have a great deal of problem with that. However, CMC, we get a lot of this. We have professionals that come into the area, and their family may be in a multitude of different areas throughout the world. And yes, they come in on their drugs, but they aren't the same drugs we have here, or they might be called by a different name. So the good news is drugs.com does actually keep a nice list, and personally, I don't like drugs.com, but they do keep a nice list of foreign agents, to which you can say, okay, so this looks like an ACE inhibitor. We don't carry that specific ACE inhibitor, but at least we can start them on another ACE inhibitor. As for databases, if I were to choose anything, it would be Martindale within Micromedics. That's probably one of the best ones. Retail, that might be a bit of a problem because you guys usually don't carry the Micromedics. Hospitals usually do. Okay, I think you guys carry clinical pharmacology. Most of the retails do. Again, there are multiple online resources to assist and ensure whatever site you choose, however, is reputable. You can find anything on the web now. Whether it's legit or not is another thing. Okay. Now, as for approved, we've got biologicals. This is a relatively new class of drugs. And here we're going to find agents like Kcentra, Factor VIII, vaccines, things of that sort that are actually going to be here. Funny enough, though, you aren't going to find monoclonals here. We're talking about mostly human blood, okay, human drug. So these agents, if you're looking for your vaccines, don't bother with drugs at FDA. You're going to want to go here to the approved biologicals. They don't get a lot of drugs that come through, and they do deal with a lot of what are called reagents. So testing for specific things in human blood. They aren't necessarily for treating. So you do have to go through a little bit. Definitely not the same workload, though, that you would get. The biologicals are in here as well. So you might find some things like a really cool one that just got recently approved for shingles is which one? Which one? Yeah, that is like the latest and greatest. I didn't include it in here. I probably should have. But yeah, Shingrix is a big deal. Why is Shingrix a big deal? Which? It's over 90% effective, yes. And what else? Is it 50 and up?
Yeah.
But there's one other big thing. It's not live, which means anybody who's immunocompromised in any way, shape, or form can take it. That's a big, big deal because these people are also individuals that definitely could have shingles, whatever time in life, just due to the stresses alone. Okay. Just FYI, here we go, colors. So if you want to know Orange Book, we already know. And does anybody know Trivial Pursuit? Does anybody know why Orange Book is called Orange Book? Anybody want to take a guess? Huh? The cover is orange, but why did they make it orange? Because it came out in October, Halloween, and they thought of pumpkins. I kid you not. One of the dumbest reasons why to call a drug an Orange Book, but nonetheless, the FDA did it that way. Red is actually toxicological principles. We don't deal with that a lot. That's mostly industry. Purple is those new biosimilars and biologicals. Blue would be devices. Now, we're going to get into this in just a moment here, but devices you need to care about as well. A lot of people overlook this. A lot of pharmacists overlook this. And a lot of the products you dispense are actually devices by nature. We've got the Green Book we already talked about. Yellow is international travel. And this is by the CDC. And then the CDC also does the Pink Book. Now, as you can imagine, for students, this gets really confusing because we have the pink sheet, which is industrial discussion and who's doing what, and new drugs coming out. We've got the red book here, but the red book is also what to students? It's also taught in micromedics as a price place, right? Where you find the cost of a drug. And then if you go out into the hospital setting, it's actually got a slang. The red book is actually AHFS. It has picked up that nickname. So understandably so, your students can be really confused by this. This might help them out a little bit. It really does depend on who's writing the word, orange book, red book, whatever. Okay. Illegal drugs. So this is probably the area of drugs I am the least knowledgeable about. I'm clueless on this stuff. When they said bath salts for the first time, I really thought it was bath salts. And I was like, why are you sniffing that stuff? I mean, it's rose flavored, who cares? And finally somebody decided they didn't want me embarrassing them anymore, i.e. my oldest daughter, Taylor. And she says, Mom, that is not literally bath salts. It's just the way it looks. So DEA does definitely carry some really nice information on this, patient information leaflets, things of that sort. So if you're going to look for illegal drugs, this is the place to go, is with the DEA. There are many reputable and questionable websites that are out there. I'm sure there are many places that will teach you how on the web to make methamphetamine and whatever new agent that's come out onto the market illegally. What's the new thing that's out from China? It's like fentanyl wannabe. What is it called? Yeah. So these are all new agents that we don't even hear about. Why? Because we deal in the legit, not in the illegal. So Poison Dex, however, is a nice place to go for this stuff. Obviously, you can't identify it, though. Let's get clear about this. Everybody says, can you identify this illegal drug? No, I can't. Okay, somebody compounded it. They aren't putting a little stamp on it. Okay, although there are some freaks out there that do. Okay, investigational. So if you're going to look for investigational drugs, probably the two best places to go would be clinicaltrials.gov. Why? What's the unique thing that happened? I think it, again, was in 2005. And this really changed the world of publication. So up until that time, 2005, over 70% of articles that came out about drugs were positive. They had positive effects, and only 30% were negative. Why do you think that was? Yeah, publication bias. They didn't have to publish it. If it was bad, they just didn't publish it. You never knew about it. Well, obviously, that can't happen anymore. So clinicaltrials.gov, you want to do anything to a human being with a drug, you have to register. Otherwise, you ain't getting it published anywhere. And plus, the IRBs won't allow you to do it at all now. So clinicaltrials.gov is a place to go. You can either find what's currently going on, what's just closed, what got nixed out. Like I was looking at a website on a newer drug that everybody was just raving about. And they were talking, it was Exparel in rib pain. Okay, which sounded like a great idea. However, one of the studies got kicked out because they never bothered to get approval like from the IRB on it. Yeah, whoops. So there's a whole host of unique things, and by the way, they tattled on them big as day about they never got approval. Publication studies, if you want to go anywhere, PubMed, Medline, it's hit or miss whether you get a full article or not. FDA approved devices, again, a lot of people don't think that this is pharmacy necessarily, but it is, because why? What are unique drugs that actually are devices? Can you think of any? Huh? Possibly. I think lidocaine can go back and forth whether it's a drug or whether it's a device. What were you going to say?
The 24-hour patches that you can actually push, like the insulin and the Preceptor.
Oh, I'm not positive on that one. I can tell you the drug-eluting stents are definitely devices. And so whenever you get into something like this, you need to not say, well, I've never heard it, the FDA doesn't have it. That's not necessarily correct. You need to go to the device section, okay? And a lot of that stuff sits in the device section. So just kind of keep that in the back of your mind. If you aren't finding it in the normal sites, you might have found it here, especially if it has any physical entity to it besides just the drug itself, okay? However, fair warning, there are some drugs that aren't classified necessarily as drugs that are actually devices. For example, when you go to get an ultrasound, that goo that they use for an ultrasound, I don't even know what it is. That's actually a device. So, yeah, I'm sitting there going, huh? But it's actually considered a device by the FDA. Okay, alternative and complementary medicine. The hospital doesn't deal with it, however, you soon will in 2019 because you get to deal with marijuana. Okay, how West Virginia will allow marijuana. In the retail sector, y'all deal with it all the time. So where do you go to find reasonable information about it? You can go to the NDC database. Again, they will list those alternative medicines that are there along with everything else. You can hit the NIH. It actually has a unique site for it, which is called the National Center of Complementary and Integrative Health. Everybody just calls it the CAM. And you'll find studies in there. Now, as a purist on evidence-based medicine, I'm not particularly fond of that site. When they initially came out with the information, everything was supposed to run like a typical randomized, placebo-controlled, high-level evidence-based study. But with the first set of negative results, the CAM said, well, that's not how you evaluate alternative medicine. Alternative medicine is unique to a patient, so we can't necessarily measure it that way. So it kind of went back to more like a case-based evaluation, which I'm not necessarily particularly fond of. Natural medicines database. This is probably the best by far of the databases. Yes, you do have to pay for this one, unlike the rest. Pharmacist letter carries this with them. The nice thing and the very unique thing about this is that they also list the brands. So most alternative medicine databases will only list the ingredients, usually individualized. But Natural Medicines database actually lists the brands that have those products in it, what the brands have in them, which is really nice, especially in the retail sector, because you got different agents coming out all the time on this. Irradiation, again, probably what most people in here would not deal with. I happen to know only a little bit about this because CMC actually has a nuclear pharmacy. So we do look at that. A while back we decided whether we were going to add this as part of formulary with CMC, and it was decided kind of just to leave them out of the loop at this point because they serve more than just CMC. But yes, they have their own rules to abide by, not only the West Virginia State Board of Pharmacy, but they've also got there's a nuclear group where they have to abide by other rules relating to that process. Finally, compounded drugs. This has probably been getting the most heat of all within the drugs that are available. There's a lot of argument that goes on about this. It's almost become like a witch hunt. If you ever go into med alerts within the FDA, you can get this as a monthly FYI. It can even be sent to your phone if you would like. You just have to subscribe to it. It's like they have 2 or 3 almost every month of mom and pop stores that they just shut down for compounding violations. So there's been discussion within the literature about whether they'll even allow compounding anymore. Hopefully that will not be the case. I think compounding definitely has a place in practice. It really does. I think it just needs to be clarified as to what kind of environment you get compounded and where you can push that. Now, as for literature on how to compound, that gets a little bit dicey. The reason being is that these guys hold their compounding recipes very close to the chest. For example, I bought 2 articles from their journal that is several $1,000s to purchase. 2 articles that were 3 pages each. It cost me over $100 for 2 whole articles. I mean, you might as well sell your first kid. But nonetheless, I can appreciate where they're coming from because this is indeed their bread and butter. And then finally, this doesn't apply anywhere, but it's a big deal. As for drug availability, we got drug shortages. Okay, has anybody dealt with drug shortages? You might as well all raise your hand in this room. Drug shortages have both pros and cons to it. Obviously, they're a pain. They delay patient care in some cases. But the unique thing about them is you bring out your pharmacotherapy skills, you brush up on your guidelines, you all of a sudden learn what are your alternates, because you aren't in that dogmatic mundane anymore, because you can't be. For example, the latest one is the opiates. So let's see, fentanyl went out, and so what did everybody go to? Morphine or hydromorphone. Well, those two went out too. So now you have no fentanyl, you have no morphine, no hydromorphone. People then went to Demerol. Oops, that went out too. So now you have to get an IV drug to a person, and you've got this left, okay? They're coming up with new and unique ways to deal with pain, and every institution in the United States is dealing with this nightmare. And the sad part about it is this nightmare will continue until at least September. The opiate crisis, which is a crisis in a different way to us, is going to last until at least September. All because of one thing. Does anybody know what happened that caused this entire problem? A hurricane. Why we put all our eggs in one basket, God only knows. But yeah, that hurricane not only led to opiate problems, but it led to the bottles that we used to make for the opiates, and lorazepam and all these other things that have special needs for when you go to handle them. It also dealt with normal saline, it dealt with heparin flushes, it dealt with just about every major drug class you could think of that was considered part of the mundane. So if you didn't have dextrose, you went to normal saline, but you don't have normal saline anymore. Why? Because the dextrose went out. So it definitely has made us much more creative, and I really do believe much more clinical in our practice. This is a new area that we can focus in on with our students, because they have to be ready at the drop of a dime that, oh, I'm sorry, no, you can't prescribe that today because it's out. Now, what are you going to go to next? This is your patient. And I'll tell you what, they're brushing off what you taught, which is wonderful. So just keep cornering them and teaching them this, because they will get it for the rest of their life. We're stuck with this. I don't see it going away anytime soon. I really don't. Okay, so again, I told you we're going to focus on these first two boxes, the biologicals and the FDA approved drugs, and we'll go through just a couple of them. As a reminder, these are the subclassification types, and probably the big one, if you're going to look at anything, is what's called that priority review. There's a lot of argument on a priority review. A lot of people say, well, that's just whoever paid the most money to get it through the pipeline fastest. I don't necessarily agree with that, but nonetheless, an FDA priority review is a priority review, and it needs to be paid attention to. Standard reviews are the norm. They run through the normal pipeline and length of time. The big things we'll focus in on are new molecular entities and new active ingredients. And then we've got one drug that we're going to talk about that's a type 1-4. So this one is a new molecular entity that happens to be a new combination. Okay. First drug up, angiotensin 2 acetate. So when you think of angiotensin 2, what are the drugs you think about? Huh? ARBs and ACEs. ACEs and ARBs, except for this is the exact opposite. Okay. So now angiotensin 2 is actually being produced, and it's a vasoconstrictor. Totally makes sense. You're going to use this drug in probably your sickest of your sickest. So you've already tried some of your other vasoconstrictors. So we've got norepi, epi, vasopressin, those things. And it's been found that this drug seems to help these vasoconstrictors in improving blood pressure. Specifically, the ATHOS-3 trial looked at this, and of course they compared it to placebo, which I always kind of get a giggle out of, because of course any drug's going to be better than placebo, otherwise why'd you market it? But here they looked at 163 patients who got the angiotensin 2 and 158 who got placebo, and they were measuring what's called the MAP, or the mean arterial pressure, to prove that indeed it went up. And they were looking at mean arterial pressure going up a certain amount within 3 hours. So as you can see, of the 163, 114 patients met that criteria, versus placebo only 37. I'm still impressed that 37 made it. but it's probably some of the other agents that they had on board, and, oh yes, they probably threw on some more fluids in the interim. So this agent definitely is coming into the arsenal. You'll notice it's a 1P. So it's not going to be uncommon at all. You in the hospital setting, somebody's going to ask for it eventually. So just get prepared as to whether you want to carry it or not. But it is, again, another alternative or an adjunct to the situation. The retail sector, no reason to even consider it. Okay, ertigliflozin. Now, I'll admit, whenever I hear this drug, I keep thinking of an antibiotic, but obviously it isn't. This is for type 2 diabetes. Obviously, it's like your canagliflozin and all the other flozins that you can think of. So it's a sodium glucose cotransporter, again, for type 2 diabetes. We've got tons of drugs out for this. And it's in tablet form, and we're talking about a daily dose. But you have to be careful for renal impairment, end-stage renal disease. Basically, watch out if you got anybody with any sort of renal dysfunction. Okay, this is probably not the agent you want to go to. Some of the weird, quirkish ADRs that you get with this, genital fungal infections. My apologies, I did not get to look into that. Those of you that are diabetes specialists, why in the world does that happen? Can anybody tell me?
Just because you're peeing out on like sugar.
Thank you.
Yeah.
Okay.
That's
Yeah.
why.
Well, that makes sense. Okay. So, of course, UTIs and things like that and headaches. As for a study, we got Hollander and his colleagues who did a double-blind non-inferiority. Non-inferiority pretty much is the new gold standard for studies, if you look at those now. And here where we were testing ertigliflozin, 15 or 5, next to Glimepiride. Now, why they didn't compare it to another agent within its class, God only knows, other than the fact that, hey, that's not a gold standard at this point. But the Glimepiride, of course, is. It's been around forever and a day, and nobody hardly ever uses it anymore because of its sulfonylurea, and it carries nasty little side effects with it. So, yes, it was non-inferior, no surprise there, at reducing the A1C when it was added to metformin, which, of course, is like the kick-butt drug of all diabetes agents. Cost is $10 per tablet, so pick and choose your poison. I would assume by now the others are probably cheaper. I would hope they're cheaper. But nonetheless, you'll notice it received a 1S status, and that would be applicable to the hospital or the retail sector. Hospital, maybe you won't use it because the newer literature is saying, what do you do with those patients that come in on the orals? You just automatically flip them over to insulin while they're in that acute phase and then put them back on it whenever they go out the door. So. Okay. Next one is another endocrine drug, and again, this is also for type 2 diabetes. It's very much like the agents that are already out on the market. So we've got exenatide and other agents of the sort. This one's Ozempic, or Zempic. Now, obviously, it's not an oral, but it is a pen, another once weekly kind of deal. It's kind of expensive. It's definitely expensive. I believe this is a multi-dose, though. Any related history of medullary thyroid, you don't want to use it. So there are some consequences of using this. Potential. Pretty rare, but potential. So that might be something to consider. Of course, like all the other agents within its class, GI upset seems to be the standard. As for studies, we had the SUSTAIN-3 trial. This is open label. I'm not particularly fond of open label, but it's kind of hard to fake your A1C, unlike your pain management. It was a parallel randomized, and you can see that it was actually compared to exenatide. And here we've got where it was pretty decent, and this was 56 weeks out, and in this case, semaglutide was actually superior. Okay. Moving on. If there are questions along the way, please ask. I don't guarantee I'll know it right off the top of my head, but I'm always more than willing to find out, or someone in this room very likely already knows. Okay? Gastroenterology. This is, I debated about whether to put this actually in the oncology section. You'll notice I didn't discuss any oncology. I make no qualms about oncology discussions. Usually most people don't care about it anyhow. But nonetheless, you might actually see this in the outpatient setting or in the inpatient ambulatory setting, if you get questions on it. This is another heavy-hitting agent for chemo-induced nausea and vomiting. So you can think of some of the regimens that are particularly troublesome. And this new agent, the NK1, like the other agents at Preceptor and those agents definitely can help out with this delayed nausea. So it not only works for immediate, but also delayed nausea, which is kind of nice. None of it's cheap. No surprise there. Again, we're talking about $672 for a 300 milligram cap. So, okay. Everybody's been listening about this. Anybody dispense it yet? Probably not. No. Yeah. This is the new 10A that just came out the door, like all the other 10As that are now down on the bottom. The new wannabe warfarins. They're much better than the warfarins as far as I'm concerned. I think these are quickly becoming more of the gold standard, which is good. There's really good news right after this. We'll be talking about that antidote with regards to that. So the APEX trial is probably the biggest one we're talking about in this situation. They looked at thromboprophylaxis in hospitalized patients. Now, they did a comparative between the Bextraban and the enoxaparin. So you notice the difference in days, 35 to 42 days versus 6 to 14 days. Here they were looking at anything that was symptomatic, like thrombosis, PEs, VTEs. That was their primary endpoint. And in this case, Bextraban had a 4% incidence versus enoxaparin 6% interest or incidence. And of course, no surprise there, major bleeding with the newer agent. Yeah.
Where in the world did 35 to 42 days come from? Are those patients just hospitalized longer, or did they continue at outpatient?
Outpatient.
Discharge?
Outpatient.
Huh.
Yeah. If you like, I can send you the trial. Mm-hmm. That's why I don't think it's an equivalent study, because one got treated 14 days max. The other one went out past that time, of course, that there would be problems. So as for equivalency, not necessarily. And I'm not surprised at all about the bleeding again. You look concerned. What's up? No, it's good. Anyhow, it got a 1P, so I'm sure somebody's going to want it. And at $18 a cap, pick something else. Okay, so this is my complaint. This agent, Andexa, they've been promising for what, a year and a half now, that they're going to bring this stuff out on the market. It's already been used over in Europe as an effective agent for those 10As, okay? And so finally, on May 3rd, they approved it. Yay! So you can imagine what we're going to be talking about at P&T in the next week, is this very agent. Because this is a big deal. Up until now, we really don't have a great way to monitor these drugs, other than if you're bleeding, I guess then you got a little too much, or maybe that wasn't the right drug for you, whatever the case may be, or you had concomitant disease states that were a problem. Nonetheless, unlike warfarin that you could monitor, nonetheless, these agents are really good. Why? Because you don't have to monitor them with labs. So, nonetheless, you still need an antidote for this stuff, just like the vitamin K for warfarin. And now we have Andexanet. Now, Praxbine already came out for one of these agents, which was wonderful. Now we've got this agent. I believe it's for the rest, if I remember correctly, but correct me if I'm wrong. This agent for all of them. That's what I thought. Yeah. So, yay, happy day, we finally get this stupid thing. There was another antidote you were talking to me about yesterday. What was that?
The Predaxicon got full approved.
Full
So it's
approved.
out of the
Oh, yeah.
it's
Yeah,
out of
this
that
is,
monitoring.
this is unique, guys, because this is actually conditional approval, meaning they actually have to continue on with their studies.
Yes.
Yes, yeah. So they have to continue on with their studies, and if they don't do it, the FDA can pull them right off the market again. Everybody's been waiting on it, so I'm sure there'll be enough studies out there going on. Okay. As for immunological agents, we've got the NIBs, or the tyrosine kinase inhibitors. I'm not a big fan of these agents. Oftentimes, they're used in the oncology setting. In this case, they're being used for chronic immune thrombocytopenia, where the immune system pretty much is attacking itself. The NIBs in general, they say it's pretty mild, but the funny thing is they say you can stay on a nib and it'll pretty much keep things at bay until you can't stand the side effects anymore. Yet they say the side effects are mild. And some of the big side effects are GI upset and skin rash. So I'm not too sure how mild they can be on this situation, but nonetheless, this is a big deal. However, they only gave it a 1S, nonetheless. So we got it in tablet form, and after 12 weeks, they saw a significant benefit. Now, significant benefit, the Tavesi, I think that's how it's pronounced. Please understand, they never teach pronunciation when a drug just comes out on the market. So I sound like an absolute idiot when I talk about this stuff initially. In this case, when they did the study in this one, 2 phase 3 trials, multi-center, which is great, and they did a 2-to-1 ratio. The nib had an 18% basically stabilization of the platelets. Okay, 18%, that's pretty good, but that means all the rest of them still didn't stabilize, versus the placebo that was 2%. So yeah, it's good, but it's not perfect. Okay. Are there other options? Absolutely. So we can do steroids. That'll pretty much kick anything's butt, although they carry their own severe consequences and they're guaranteed side effects. Then the IVIG, which pretty much is what I've seen mostly in use for ITP. Okay. Infectious disease would cut actually a number of brand new agents within this area, which is surprising, but I wouldn't necessarily say they're stellar, but they're brand new in nature. So we've got another fluoroquinolone. This one is in tablet or injection form. Baxdela, another fluoroquinolone. You do carry the problem C. diff that goes along with this. So that's pretty much a consequence with just about any fluoroquinolone you use. You do get GI upset, again, not a surprise. You can get liver elevation, so that might be a bit of an issue. As for studies, there was a phase 2 trial, double-blind, where they looked at skin and skin structure infections, and they were comparing, and this I liked, because it was an active control in this case. So delafloxacin was compared to linezolid and vancomycin. Great choices. The only thing I don't know is if that 15 milligrams per kilogram was necessarily appropriate. So in this case, they found that linezolid and delafloxacin are pretty much equivalent on basically eliminating the infection, but the vancomycin wasn't as good as those. Again, I'm not too sure on the dosing with that.
This is just for MRSA?
This, I'm sorry, what?
Was it mainly for MRSA then?
Don't know exactly off the top of my head with regards to that.
Based on summer.
Yeah. So we do have other agents, other fluoroquinolones, but this one does carry a different spectrum, slightly different spectrum. So, okay. I've got 2 agents to show you that are for hepatitis C. If we've made any great changes, it's with the Hep C, which definitely in the state of West Virginia, that's one of our biggest problems. It's absolutely amazing. I never realized we were that bad. But these set of agents are amazing because they are the cure, which is phenomenal. I can't say enough about them. In this case, the Mavret, we're talking about an agent similar to the other antiviral agents that covers 1 through 6 on the GT, which again is pretty good because I think some of the newer agents was like a 1 and a 3 or different units of it. Now this one covers across the board, which is good. 3 tablets daily. Now, look at the cost of the tablet. We're talking about $188 per tablet, okay? but we're talking about a cure. So here you're looking at cost versus benefit. Overall, are these patients going to end up in the hospital if they don't get treatment? Sure. However, it may be years and years and years down the road that they would need that coverage. Still, nonetheless, it is a cure. So depending on what you're treating, you could be treating for 12 weeks, or you might with the GT3, or you could be treating for as long as 12 weeks. So, and that's the GT1. So with regards to studies, there's a number of studies in there. I didn't necessarily give a lot to you on this, but as you can see, they're pretty much equivalent to a lot of the other GTs or the other hepatitis C agents. Another one that, again, went across the board, 1 through 6, another oral agent, of course. This is only $1,000 per tablet. And as you can imagine, obviously the patients aren't paying for this, guys.
This one you can use in treatment experienced patients, so they fail
Mhm.
to interfere on it.
Yeah. Yeah. And it definitely was a little better with the newer agent added to it, because this is just, you know, the same agent. I don't remember the brand of it that had the Fosbuvir and the Velpatuvir. Those two are already a single entity, and then they added on the other agent. So here in this case, in the Polaris 1 and Polaris 2 trials, these are both phase 3. You can see where they were compared to placebo as well as an active controlled, again, randomized controlled trial, and to sustain virologic response. We're talking about pretty much equivalent on the agents, but definitely a little bit better in the triple therapy. Okay. The whole big deal, you got to make them take this stuff, and they got to be consistent, just like any drug. But I think this is particularly irksome. It's kind of like the HIV drugs. You cannot stop. You can't skip. You must be compliant 100%. So if I were to push anything, that would be a big deal. One of the concerns, rifampin, of course you can't use that in co-administration. Okay, moving on. An agent to basically to compare to Zofran. That's already sitting in just about every hospital out there, and this is Vabomere. Okay, Vabomere. Used for UTIs or pyelonephritis. You can see the injection here that is used for it. You have to watch on GFR because you actually dose based on the GFR. So you can go anywhere from 2 grams Q8 hours all the way up to, or actually all the way down to 1 gram Q12, depending on the GFR. Of course, just like any other beta-lactam, you can't have an allergy to this. And as for adverse reactions, we got C. diff going on here. That's a given with any of these broad spectrums. Steve, you're laughing.
Lots of this.
Well, yeah, unfortunately. And CMC is really good at C. diff, so. But fortunately, you know, we've got some newer C. diff agents out there. Tango was a non-inferiority study, and it actually looked at this agent compared to Zofran, which pretty much is the end-all. And you can see a 98% versus a 94%, pretty much equivalent in nature, a little bit broader spectrum. I can tell we actually approved it over next door, but under ID approval only, just to prevent what you were talking about, you know, the resistance and all these other problems that go along with it. This is a good one. This actually is sparking controversy in some of the hospitals. However, the retails are going to be thrilled to death. Now, as you can see, this is not necessarily a brand new entity. This is a 5P, so it's a new formulation. And this is Vancomycin Solution. Finally, how many of you have compounded Vancomycin Solution for oral? If you're in the hospital setting, that's what you've been doing for years. Why? Because IV vancomycin is $9 per vial. It's dirt cheap. And yeah, it tastes really, really bad, but you throw a little cherry flavor in there, and given the fact that they're sick already, they usually chug-a-lug it down just to get rid of the absolute pain in their gut. So that's what we've been doing for, I can't tell you how many years. Matter of fact, even in the Vancomycin package insert, the injectable package insert, is actually a recipe on how to compound it orally. Now, here's where we're coming up with a bit of an issue. Now that we have this new formulation that is an oral solution, can we still compound it? We can't. We can't. We cannot compound this. And there's been a lot of discussion. Well, wait a second, Vancomycin has it in their package insert. Isn't anything in a package insert something we can compound then, if they've officially been FDA approved? It is to that point that that drug was not an oral solution available. So this is the new commercial agent, and if you look at the laws, the FD&C laws, 503A and 503B, you may not compound a product. Now, there's yet another minutia to this, because is this law or is this policy? This is actually policy. So what is the difference between law and policy? Basically, thou shalt not is a law, thou shouldn't is a policy. Okay, so this is sitting as a policy, but basically you'll get guilted into using the commercial brand now. Why? Because you have less chance of a screw up on compounding. It's now an appropriate formulation that was intended for it. And if you have any screw up whatsoever on that IV that you made for that patient, it's your liability, because you didn't use what was already out in the community. So yeah, this one's, people are going to feel a little bit of a sting with regards to cost. But unfortunately, or fortunately, however you look at it, this new agent definitely is going to help retail. There's no doubt about that. And I think it's necessary for even the hospital setting. You were going to ask something, Hannah? No.
Or a bottle?
It's a bottle. It's a bottle. It comes with actually a solution that you compound it with. Yeah, I know. You're sitting there going, I could have done that already. I know. But they gave you the solution to add it to. Oh, and it's in grape taste instead of whatever taste we make it. Okay. So miscellaneous agents. This really isn't for hospital. This is more retail. So Bausch & Lomb came out with Vyzulta, and this is an ophthalmic agent. It's pretty much like every other prostaglandin agent out there for open-angle glaucoma. Nothing stellar about it. It's good. It works. It's better than timolol, but they should have compared it to another prostaglandin inhibitor in order to prove that it really was beneficial. But it's better than timolol, which is considered the gold standard for open-angle glaucoma. And it did increase perfusion. It was effective, but both were effective. So you pick and choose whether you want to go with prostaglandin. I probably wouldn't go with those first, though. So you can see all the other agents that are already out. Timolol's dirt cheap. Absolutely dirt cheap. Repressa. Now this one is a new agent altogether. This is a Rho kinase inhibitor, okay? So I gave you the specifics on the mechanism of action because unlike the prostaglandin and the beta blockers, this is totally unique. This goes through the trabecular pathway, decreases cellular contraction, and then also prevents fibrinolytic matrix proteins to develop, okay? I know that sounds kind of weird, but if you look into the eyes, the anatomy of the eyes, you can kind of make sense of it. So this new agent, of course, isn't cheap at all, so $274 per 2.5 mLs. Obviously not a first thing to go to. But it does work. Some nasty side effects go along with it, though. So hyperemia, we're talking about the blood vessels that are in your eye that you can barely see. You will see it potentially with this drug. You'll look like big whopping veins in your eyes. It's really gross. If you look at the internet, you can see actually the pictures. It's gross. Throw on top of that the corneal issue that goes along with it. And if you look at the pictures again on the web for this verticillata. Anyhow, it looks like spider webs over your iris. Okay. spider webs and big red blood vessels. Definitely not a first pick for open-angle glaucoma, but it is there. Okay. So let's go ahead. My apologies, we're stopping a little early. Is that okay for you? Okay. So first question for you. Distinguish areas within the FDA where medications are updated. Anybody want to throw out some to me?
You talk about the books,
Books, whatever.
so you have the different books, like the ones.
What about the databases? What are the different databases we talked about?
Like talk about like microgenetics,
No, that Micromedics doesn't belong to the FDA.
Separate NBC codes for the house.
I'm sorry.
They get the separate NBC codes for the
Mhm.
house.
So the NDC database, we've got drugs at FDA, we've got the biological site, so those are some examples there. Explain the mechanism of action and where newer agents are being used. So we've addressed a ton of mechanisms of action. The vast majority of what we discussed today were agents that already had sister product out on the market, okay? Had a few new ones. Probably the one that I found really the most interesting, other than the antidote that I couldn't get any more information on, is the angiotensin 2. I think that's cool. To me, that's a great idea. So as for example, yeah, vasoconstrictor angiotensin, it's part of the body. If it's something the body already naturally does, it obviously works. Fair warning on that one, though. Did you guys notice a side effect that goes along with this product? Does anybody notice a really huge side effect with this drug? It's a big deal. Yeah. Thromboembolic events, 10%. So before you use it, take that into consideration, 10%. That's a lot, but pick and choose how you're going to die. You can definitively die of the shock, or you may die of VTE. Okay, describe the difference between bioequivalent and biosimilar. Anybody want to try their luck on that one? Go for it, Hannah.
Bioequivalent is like automatically substitution approved. Biosimilar, you have to have permission from the prescriber, you have to notify the client and the prescriber afterwards, and it's not exactly pharmacokinetically the same
And,
type of.
right, and each state has to have law on it. So that's probably one of the big things. Let's see. Identify which new agents are specialty and/or REMS. Now, specialty is insurance companies, as we talked about, but REMS, none of the drugs we discussed today are REMS drugs, but on your sheet, you have 2 brand new REMS drugs. The cheat sheet I gave you guys, this thing. It's in the small print. So in this case, you've got a drug I definitely can't pronounce, and then a drug underneath that that is even worse. So my apologies, but I embarrass myself enough monthly on these pronunciations. And trust me, there is nowhere on the web, nowhere, you can find the correct pronunciation, which really is annoying. Okay, so hopefully that will help you. If you guys got any questions, I am more than willing to entertain them. Nope.
Do we do anything special to provisional drugs in terms of monitoring them? Or is that just?
No, I know exactly what you're talking about. Are you talking about CAMC or?
Like is there any outside of just reporting adverse effects?
The company mandatorily has, there's no choice. And if you read the letter to this, the Indexa, they've got a specific study they want the company to do. They're very, very absolute about
It
it.
doesn't require extra work on the prescriber or on the system.
Not at this point. It really, when they mean provisional, they really mean provisional. And so when you see the package insert come out, it's going to have wording in it that it currently is approved for use. And that you kind of get the inference that they can pull it off the market anytime they darn well please. if the company does not do the studies that they were required to do, the post-marketing studies. So, and that definitely is brand new. That is brand new. Just like on, if you look at the classifications in the NDC database, there's a brand new classification in there, which I thought I'd never see. It's unapproved drug for drug shortages. So we've actually used some of those drugs in the United States, and you may not have even realized it. Can you guys guess a few? It's mostly hospital, though. So propofol seems to go on and off the market all the time, and we use this company called Freeseas. You ever heard of Freeseas? They're based out of Australia. They love supporting us for drug shortages. They make a mint off of the United States for this. So Freeseas is like, they got to be kicking butt, man. I'd invest in them if I was going to do anything, because they've supplied our propofol, they've supplied our, the sodium bicarbonate they supplied. They have supplied some of our calcium chloride and calcium gluconate. I'm trying to think some of the other big shortages that, I don't remember that one. I honestly don't. But yeah, they pick some of the ones that, yeah, you just can't get away without utilizing. Any others? Cool, thank you guys. Sorry for being so short.
All right, well, we'll go ahead and get started with our second presentation, our last presentation. And Jane, Cassie, Stephen, and I are kind of tag teaming this one. So we thought by the end of the third hour, we'll try to keep you as entertained and engaged as possible. So we'll switch it up every 20 minutes or so. But I want to thank Shelley for providing the drug information update. So that's sort of our clinical topic for today, and this is more of our precepting specific topic, which we try to hit on with these symposiums. So we're going to talk today about EPAs, so entrustable professional activities for new pharmacy graduates. And just by a show of hands, how many people would say they're familiar with this terminology or really know what an EPA is? The people that had to put the presentation in. Okay, good. I'm glad you guys are. So good. And I think for faculty as well as non-faculty preceptors, it's one of these new terms that we haven't talked a lot about yet, but that we're definitely going to be hearing a lot more about in terms of our students and what the expectations are, particularly on API rotations. So what you should be seeing from your API students is really where this applies. And then if you're involved in residency programs or precepting residents, what you should be able to expect that they will do when they come out as a resident or as a new graduate if they don't do a residency. So our objectives for the entire presentation are here for you. I'm going to really go through the background of what EPAs are, how we use them, and then how we specifically use them within our experiential assessments and curriculum. And then Jane, Cassie, and Stephen are going to talk more about the application of the key assumptions for EPAs, which we'll talk a little bit more about. So communication, professionalism, and self-awareness. So those softer skills that I think when we have challenges with students, that those areas are predominantly underlying those challenges in a lot of cases, and some of the harder, more sensitive issues to deal with are not as objective. So ACPE is our accrediting body, for those that aren't familiar with ACPE, and they revised their standards in 2016. And when ACPE revised the accreditation standards, we saw a lot of new terminology and a lot of new things that we have to do in terms of preceptor development. We have to make sure our preceptors are aware of, our students are aware of, and we have to make sure we're assessing pretty much everything that we do. So one of the big changes we saw, or differences in the standards 2016, are these terminology: API ready, practice ready, and team ready. So they want to make sure when we're designing our curriculum from the first year all the way through the rotations that, one, they're prepared to go on rotations. And I always tell the students, I think the expectations for what an API student should be able to do now are much higher than when I was in school. So I feel we didn't have IPPs when I was a student, and I feel like when I was on rotations, it was sort of more as like a 4-week observational experience. You kind of show up, you get a feel for what's going on, and you move on. And now we really use our IPPI rotations to do that. So by the time our students get to APPI, they should be ready to go, and they should be doing things under the guidance of their preceptor when they're out on these 5-week rotations. When we talk about EPAs, we're really going to be focusing more on practice ready and team ready. So that's really where these apply. So APPI ready would be a different conversation really of what we're doing in the curriculum. But when we're talking this, think about getting people to be practice ready, meaning can they provide direct patient care in a variety of healthcare settings. So our goal is to graduate a generalist, and team ready. And that's the other big emphasis right now from not only ACPE, but all of the accrediting bodies for healthcare professionals. We are all seeing a push for interprofessional care, collaboration, and making sure we train our students for that in the didactic curriculum and also in the experiential curriculum. And then with 2016 standards, we again see much more of an emphasis on these critical educational outcomes, so linking everything together through the whole curriculum and assessment. We have to assess and document the assessment of everything, and really we saw a lot of changes within the experiential standards and what we have to do in terms of assessment. So those that have been preceptors for a while know we changed our assessment tool. We are now requiring a midpoint and a final evaluation. Feedback's really important. So that's where a lot of this has come from. How about pharmacist patient care process? How many people are familiar with that terminology, PPCP? Good, okay. So, and this is sort of another new big terminology that we want everybody to know. ACPE wants everybody to know, and PPCP is how we'll refer to it. But this is really the purpose of this model, for those that aren't familiar with it, is to really have a consistent, standardized definition for what pharmacists do. So that we can measure our outcomes, our delivery, so that when we get working for provider status, we're all speaking the same language. We can show our outcomes, and we can get reimbursed for what we do clinically in some of those non-dispensing type activities. And this is what it looks like. So this is sort of what, if we throw up this wheel, and we've kind of integrated it through our whole curriculum as well, we want all of our students and all of our preceptors to know when they see this wheel, this is the pharmacist patient care process, or the PPCP. And for us that practiced before this came about, it's basically pharmaceutical care. You know, it's a new word for what we've always done, is really how I think about it. But it's really kind of standardizing the process for what we do. So collecting information, assessing it, making a plan, implementing it, following up, monitoring, evaluating. So they're really making a big deal about it, but you know, it's really just how we practice and getting students to think through that thought process. So when you see, we've tried to put the terminology in our syllabi and in our experiential handbooks. It's on the assessment tool, so use the pharmacist patient care process to do this, to do that. And that's just so our preceptors will get familiar with the terminology, and everybody will be able to speak that same language. We also, like we say, we really push it to the students, so the students can help reinforce the terminology with the preceptors when they're out on rotation too. But we're using it throughout our lab series. Jane uses it in their IPPI orientations in her simulation. We're using it in pharmacotherapy courses, so the students are seeing it throughout.
Are you guys in flip, or can you go back to that slide?
Mm-hmm.
Are you guys putting equal pressure on all of those areas, or are there specific areas that you're really impressing upon the students?
In the didactic curriculum?
Yeah.
Do pharmacotherapy people do?
Okay.
Assess and plan. Yeah, because when they're writing their SOAP notes, they're not even writing the S&O anymore, right? They just write the assessment plan.
They can easily, I've noticed that they have an easier time collecting the information than actually assessing the information that they collected and then coming up with a good plan. So in pharmacotherapy right now, our big focus is, the assessment plan.
The one thing I'm a little worried about, and clerical practice alone, especially to the older pharmacists. We've been taught to do collect, assess, plan, and implement, but we've not been really good at follow-up and monitoring because we were never paid for it. Now with like the new MTM and things like that, we really need to put that into the final route and then start back again with assess and plan. And if we could push that, that would be great.
I think that's a good point, and that is probably something that I don't know, I could be wrong, but I think it's harder to do in the didactic curriculum, and I don't know that we do that as much.
I put it in about for 3 years now in the ADR one, and it is hard, but it's imperative.
Yeah, I agree. It's a good point. Yeah, so that's fine. I would agree with Carrie too. I think when I grade SOAP notes for 716, they fall apart in the assessment section. They don't really seem to understand what assessment is. They're really not thinking beyond that. So that would be something good to watch out for on your API rotations too, when you're quizzing them and figuring out, do they really have a good, solid, in-depth understanding of where their assessment needs to be. So EPAs, untrustable professional activities, I'll call them EPAs because I have the tongue twister for me, this is something that medical schools have been doing for a long time, so it's basically borrowed from the medical model. And it's really defining and assessing pharmacy practice skills. So again, we're looking at the purpose of this was to develop a framework across the API curriculum is really where we're looking at. So when we think about what we want our API students to be and what we should be able to trust them to do by the time that they graduate, again, we're thinking about a generalist practitioner. So any thoughts on when you guys think about a general practitioner or what you want an API student to be, what does that look like to you? What are you looking for in an API student on your rotations?
I mean, I'm generally looking for somebody who can get through that wheel.
Okay.
They should be able to collect information, analyze it, and put it into some type of practice. And they should have some framework of knowledge base about major disease states.
Good.
It should
Getting
be
through that wheel, like, in a timely manner. That's the thing is, like, at first, especially when students start off on rotations, it's, okay, we don't have an hour. The provider has asked us to come up with a recommendation right now.
They also need to be able to assess their environment and what exactly it is they're focusing in on, whether it be retail, hospital, clinical, whatever the case may be, and adapt their answer to that situation.
So the other thing, just to mention, is competency-based assessment. So when we think about competency-based assessment, when they talk about EPAs in the literature, they talk a lot about competency-based assessment. So basically, it's looking at a way to prevent students from graduating without demonstrating their abilities to do things and to be effective clinicians. So making sure that there's something in place that, we don't just, they get through the curriculum and then we don't just send them out to practice. So it's really requiring students to demonstrate competency rather than assuming it's met at the end of the degree program, which direct observation, obviously from the preceptors, is essential to that. And we kind of think of the preceptors as the last line of defense to really evaluate practically and clinically, are these people ready to practice? So this is nothing new. This is something that we've always done, but it's sort of background that's kind of led to these EPAs. And I know from a preceptor perspective, when we have challenges, especially with our external preceptors, it's not always easy to predict what students are going to do well in the API setting and who's going to struggle. We've had students that have done very well academically, but then we get them out there in the API settings and they can't communicate. They can't talk to people. They can't relate to people. They can't put things together or do it efficiently. We've had students that have struggled academically that we have worried about sending, and they get out on rotations and they blow it out of the water. That's where they really shine. So it is hard to predict that, and when preceptors call, and nobody wants to be the preceptor that fails a student in their 4th year. And we don't want our students to fail. We're there to support them and help them. But we want you all to know that it's not a bad thing if you fail them. They may be one that, again, it wasn't easy to predict what they were going to do. Just because they get through the didactic curriculum doesn't mean they should automatically pass through the 4th year. So definitely an important part of the program.
So if we fail that student, what do we tell the preceptors will happen to that student? student? I mean, do we give that student remedial education? Because I think that might be part of the problem.
Yeah, so we usually, if a student fails or is at danger for failing, I'll talk to the preceptor before it happens. We'll talk a lot on the phone. But what happens is there are students, we have a committee that they meet with, and that committee decides ultimately what the next steps will be. A lot of the time that is a remediation. So it doesn't mean they'll be kicked out of the program, they won't graduate, they'll be delayed in graduating, but they will be remediated and worked with a little more closely, longitudinally. We see where their issues are. And then EPAs really translate those competencies into clinical practice. So these are the more specific descriptors of work. And when we look at these, they're going to require multiple competencies of a more holistic manner. So that's when they'll talk about the communication and the self-awareness and professionalism and all those things. So this is just sort of a comparison. You guys are familiar with outcomes and learning objectives. That's all terminology that's in our syllabi and that's there. So again, our competencies, our outcomes are really what that defines what the good pharmacist is going to be. So those are more the broad, overarching things or descriptors. So are you self-aware? Are you professional? Can you provide patient care? Do you have the knowledge that you need? Our learning objectives are a little more descriptive of those skills or behaviors that you want them to exhibit at the end of the learning experience. And then our EPAs, again, are those descriptors of work. So specific tasks that they are entrusted to perform day to day. So they're not mutually exclusive. It can be a little bit confusing. There's a lot of overlap. And again, those EPAs require integrating a lot of these different competencies and learning objectives. So this is just the definition of an EPA. Again, they're activities, so they're independent, executable, observable, measurable in their outcome. And the bottom line is, at what level do you as the preceptor trust the student can do these activities by the end of their rotation? So, and if you think about it, and I hadn't really thought about it like this until I was reading some of the articles on EPA and the background information, but they really are a better descriptor if you say, I trust the student to do this with no supervision, or I trust that the student can do this if I'm stepping back and watching and not intervening, versus you just tell them they're not doing a good job or they're deficient. It gives them a little more direction, and I think it gives you a better direction as a preceptor and really where they should be, where they are, and how you're assessing them. So they're expected of all graduates independent of practice settings. So they are the baseline now expectation for what students should be able to do when they graduate. And I included in the folder 2 handouts, Appendix 1 and Appendix 2, so you can look at those and see what they're, and I included one example in the slides, but not all of them. So you can kind of look at those tasks and get an idea for what is the expectation if you're not sure how to assess the student or what they should be doing. Again, baseline, not a ceiling, and for the generalist practitioner. So the domains, again, should look pretty familiar. They line up nicely with our outcomes anyway. So it's patient care provider, interprofessional team, population health, information master, practice manager, and self-developer. So ACPE, with this new update and these requirements, has done a better job of tying everything together. So all of these different requirements that we're expected to meet and assess are now kind of all speaking the same language as well. And we adopted the outcomes for our APPE outcomes. So when you're assessing a student on their rotation and you're assessing practice manager, interprofessionalism, you're assessing all of these outcomes, and that's what it's tied back to. So the patient care provider domain is just an example. Again, you have the handouts of the AACP core EPAs. So the specific domain is what's actually evaluated. So collecting information to identify a patient's medication-related problems and health-related needs. So that's one of our core EPAs, something that's expected, and that's what you would be evaluating when you do their midpoint and final evaluations. And then the handout gives example supporting tasks. So if you're really not sure what that means, you can refer to those specific tasks to give you some ideas. We have really incorporated all of this into our syllabi for you, so I'll show you that in a second. This is how AACP defines the core EPAs. So again, really looking at what you trust them to do. So if they're a level 1, you only are comfortable with them observing, not actively doing anything, even with direct supervision. So they're really not able to do that at all. Level 5, supervising more junior colleagues. So you trust them so much that maybe they can help with your IPI students and teach them some things. So this is how AACP defines it. We've adjusted it a little bit for our evaluations. And so I'll just show you how we have used it and what you're seeing from us in your API syllabi and manual and all of that. So in the patient care provider domain, again, it's what's evaluated. We, again, look at progression throughout the curriculum. So this is something that's introduced in pharmacotherapy and our other didactic courses. We reinforce that with students in our skills labs and simulation activities throughout the curriculum. They have the opportunity to practice this, and I used our community syllabus as an example. So for this specific example, they have the opportunity to practice these things in their community-based IPIs. And then the expectation is that they repeatedly perform these things during APIs and they move from lower to higher levels of entrustability. Now, sometimes that depends on the student. In my mind, I kind of think about our API rotations, blocks 1 through 3, they're just getting started. My expectations for them in terms of entrustability are a little bit lower. 4 through 6, they should know what they're doing and they should be comfortable, so you should be able to trust them to do things a little bit more. Blocks 7 through 9, they're at the end, they're ready to go. You should be able to trust them at the level of these EPAs that we're going to talk about because in a few short months they're going to be out there. So that's, again, just sort of how I think about it. This is an example from our syllabus, and again, the community API syllabus, but just to kind of get you guys familiar with this if you haven't spent a lot of time with it, there's that outcome and the learning objectives that you'll find in your syllabus. So again, that patient-centered care example, you can see we have used the pharmacist patient care process there. And then that's what you'll be evaluating on their final evaluation. So it'll say patient-centered care, and it'll give that example. If you don't know how to evaluate that, this is sort of one you will probably know how to evaluate. Others may not be so clear. We've also included the specific learning objectives in the syllabus. So you can kind of flip back to that and see what are some examples of ways that I would evaluate this to give you a little more direction. And then what we've done in terms of EPAs is we have tried to incorporate those specific activities, those day-to-day things, into the course activities and assignments. So you'll see a big table or grid at the end of the syllabus. Those are where we've tried to get those EPAs in and tell you more specifically, here's what the student should be doing on this rotation type. It's different for each rotation category. And then here are the outcomes and the learning objectives that they're tied to. So again, if you don't know how to evaluate something, you can flip back to this table and see, okay, well, here's patient care, that's learning outcome 2A through D, so that's sort of where that ties in. So does that make sense? You look at the syllabus. So we've really tried to use that as a tool because we know sometimes it's not always clear what's supposed to be evaluated for what. And then our rating scale and our kind of how we've modified that AACP definition of EPAs, we also use the 1 through 5. We do give the opportunity for not applicable if it doesn't apply to your rotation. But we have defined it as student achieving outcome with minimal assistance as a level 3, which is sort of the expectation for APIs. And then no need for assistant, exemplary manner, meaning they'd be able to teach a lower level student. So those are more honors marks, 4 and 5. 2, they're requiring significant assistance. We don't want to see that on APIs. Sometimes we will, and that's okay to a certain extent. And then 1 is never acceptable on an API. So a 1 in anything would be a failure of that API. And this is how we do our final grade determination. So we scale it up from IPIs. So again, we see that progression through the curriculum. So in our IPI rotations, they can get a 2 in all of the outcomes, and that's perfectly acceptable. So that's more the expectation. So they achieve the outcome, but with significant assistance. They're still early in their curriculum. By the time that they get to APIs, the expectation is that they have a minimum score of 2 in all outcomes and a minimum score of 3, so they can achieve it with minimal assistance in at least 70% of the outcomes assessed. So they can't get all 2s and pass that rotation. They do have to have a score of 3 in every outcome at least once through the APA year in order to graduate. So they can't have a 2 in pharmacy knowledge on every rotation and graduate. That's something where we would, if we saw that happening, we would intervene and do some remediation with that student. If they get a 2 in any outcome area, we tell them that should be a red flag for them. So don't be afraid to give 2s. It's a tool for them to help them develop in the areas that they need to develop in. So if they get a 2, they're required to write, like we call it a self-directed development plan for me. So they really have to look at the preceptor's comments and the preceptor's feedback, and they have to identify some specific things that they're going to do to help themselves improve in those areas. And so we put that measure into place because what we don't want is a student to sort of just be getting by, every rotation and every 5 weeks have a new preceptor, and that can catch up with them eventually. So we want them to know what they need to improve on before they get to block 7, 8, and 9. So we use it as an early intervention tool. Any questions about that? Okay. So yeah, that's just sort of a brief background of EPAs. Again, sets of activities, tasks performed by pharmacists that we should all be able to perform when we begin practice. Those core EPAs are things that we have to teach and evaluate, and we have to be able to speak to. And again, when you think about it, think about being practice ready, really, and then team ready as well. So again, we have incorporated the activities for you in the syllabi and provided multiple opportunities to practice. So all the syllabi are different for different categories, but we have tried to intentionally reinforce certain things throughout all of them. And we look at assessment from lower to higher levels of entrustable performance, and then it's something, terminology, that our preceptors have to be aware of and to be able to assess. And then the challenge with this, and this is sort of more the purpose of this talk and what we're going to get into now, is that when you look at some of those things like knowledge and patient care and medication use management, they're more black and white, so a little more easier to evaluate, or that you can say that the student is doing this or not. But in order to be able to perform these EPAs, they say that 3 key assumptions have to apply across all of them. So the students have to be professional, they have to be able to communicate, and they have to be self-aware. And if they are not competent in these outcome areas, which we also evaluate on our final assessment tool, they are going to struggle with performing these EPAs. And to be very honest, I think this is where we probably see most of our issues. So that's what we wanted to talk about today. How do we address these? How do we assess these more difficult situations that aren't as black and white and maybe require some more, foundational issues that the students have not appropriately developed over time, or may not be aware that they have deficiencies in this area until they're out in these clinical settings day to day. So I'm going to turn it over to Cassie to start with professionalism.
So as Julie mentioned, professionalism has to be threaded throughout all of these EPAs, so that's what I'll talk about. But before I get started, I want you all to take a second to think about how you define professionalism, and whenever you have a student or resident on rotation, how do you evaluate them, or what do you consider whenever you're evaluating them on professionalism specifically? So within the CAPE outcomes, there is one specific outcome in professionalism, and it states that the student exhibits behaviors and values that are consistent with the trust given to the profession by patients, other healthcare providers, and society. And the subdomains of this umbrella domain include altruism, integrity, trustworthiness, flexibility, displaying preparation, initiative, accountability, and patient-centered care, and recognizing that we are always being evaluated by others, and demonstrating commitment to continued improvement. With regards to the EPAs, professionalism is specifically mentioned in being an interprofessional team member, an information master, practice management, and self-developer. And with the PCPP, it's mentioned in all sections of that. So professionalism is threaded throughout all of these pieces. So there's a lot of different definitions of professionalism. And this is one that is not pharmacy specific. So being professional, based on this publication, is a member of a profession who displays the following 10 traits: knowledge and skills of their profession, commitment to self-improvement of skills and knowledge, service orientation, pride in the profession, a covenantal relationship with the client, or for us, patients, creativity and innovation, conscience and trustworthiness, accountability for their work, ethically sound decision-making, and leadership. So all of these are pretty similar to what we just talked about as being subdomains of the CAPE 2013 domains. And then specifically within pharmacy, an article published in Pharmacotherapy identifies these specific tenets of professionalism. So altruism, making an unselfish commitment to serve the best interests of the patient above your own. Honesty and integrity, pretty self-explanatory, hopefully. So proper classroom behavior, maintaining academic integrity, maintaining confidentiality for patients, standing up for what's right, and recognizing that the easiest solution is not necessarily what's right, and having strong ethical conduct. Respect for others, holding other folks' feelings, needs, thoughts, and opinions in high regard, even if they don't match yours. Demonstrating empathy, compassion, and respect for a patient's privacy, and valuing others' opinions. Professional presence, conducting yourself professionally in professional and personal settings. I think that's one of the areas that maybe some students don't recognize, that even, if you're at a conference but you're out to dinner that evening, you still are being evaluated on your professionalism. And establishing trusting relationships with patients, peers, other caregivers. Stewardship, so actively participating and engaging in school, profession, organizations, and other worthwhile endeavors, and leading by example. And then dedication, so also known as excellence or duty, assuming responsibility for your own learning, again, something else maybe some students struggle with, and professional development, and then accepting and embracing the ultimate responsibility for your own learning and self-development. So how do we foster professionalism? Before we can talk about how we would evaluate it, we have to think about how do we teach it. So setting good examples, being a mentor. So don't expect students not to swear on your rotation or not to eat in patient care areas if you're doing that right in front of them. Or not to wear maybe inappropriate clothing if you're dressing inappropriately. Positive interactions with students. So along with setting good examples, having positive interactions and leading by example, showing how you interact with other healthcare professionals and how they should do it as well. Identifying and discussing timely professionalism issues, including it in the didactic curriculum, and allowing students to kind of think about what they would do, or maybe not do, before it actually happens. Encouraging student involvement in organizations and professional activities. So this can help develop their positive interactions and relationships with others, learn how to manage conflicts professionally. Recognize professionalism with awards or some type of special recognition like a scholarship. So not just penalizing poor professionalism or lack thereof, but encouraging the positive. And then setting expectations through use of honor codes. So things that could influence professionalism, your peers. So students often impact each other. Role model, so are we being professional and setting a good example? School environments or practice environments, maybe we all in the faculty are as professional as we possibly can be, but if they go out to some other setting and everybody swears there and everyone's late to work every day and nobody does any tasks that are expected of them, that's what the student is going to start to display. Setting clear expectations of the institution and of the school so they know what is expected of them. Patient behaviors can influence our professionalism and societal expectations. So now that we can define professionalism and recognize how we influence it, let's talk about how we can evaluate. So these statements all come from a publication from AJPE. There's 18 on this slide, and they are meant to be, the student is meant to self-evaluate with these using a Likert scale from strongly agree to strongly disagree. And this can kind of stimulate the discussion and potentially identify for us some of the issues that the student may have before it actually happens. And these are all statements that are related to the tenets of professionalism we just talked about. So I attend class, rotation, work daily. I want to exceed the expectations of others. I follow through with my responsibilities. All of these things are very closely tied to what we just talked about. So think of any evaluations that you've completed on a student, a resident, on professionalism. How did you evaluate them? What was the score that you gave? Was it the highest or maybe not? If it was not the highest, what could they have done to achieve that highest? So we may just kind of expect that students know what it means to be professional, and we might just assume they know what our expectations are. And a lot of times they do, right? But sometimes if you have an issue with a student, you might look back and realize, well, I guess I didn't really ever set that expectation with that student. So by using a tool like this, having the student self-assess, you could use this to set your expectations at the beginning of your rotation, and also, like I mentioned, potentially identify some of these areas that they may need to work on. So now that we've talked about defining, how we teach, and how to assess, let's practice it. So the first scenario we'll talk about, you have a P4 student on rotation at your site. They're halfway through their P4 year. A half hour before the student typically leaves for the day, a nurse approaches the student and asks a drug information question. The student researches it for the next 20 minutes, then informs the preceptor of the request and says, I couldn't find a definitive answer, then leaves for the day. The student is making the assumption that the preceptor will complete the request. Have any of you had this happen to you? I see some head nods. Okay. So this is not putting the patient first. So this is violating that altruism tenet that we talked about. So how would you handle this? And what could we do to prevent it?
I wouldn't let the student leave until, I would say, before you leave, I need you to answer this question. I know typically, you leave, I guess, clinic ends from this to this time, but maybe putting it back and saying, I would really appreciate it instead of, for you to do this. So,
Yeah.
kind of making it feel more like it's a favor, but make them feel appreciated for their efforts in staying here.
Good. Anybody do anything different?
Yeah. So when they come on rotation, I'm pretty lax on time. But the comment usually is, look, your day is usually this to this. However, we've got these days to this, and it can change. So I can't guarantee you any hours necessarily, other than we got to do what we got to get done. And in most cases, it's fine to get out even early in many cases. They don't seem to have a problem with it. And usually what they do is if they do have a situation where they have to get out because of an appointment or something or an interview, they usually tell them.
Good.
I generally would, I would generally let them do what they feel like they have to. If they feel like it's time to go, tasks that they were supposed to do and make them realize that they did not follow through, they didn't put the patient first. So I think it's still an area of, learning situation that they could, miss a question wrong on an exam, you should never forget that. So I think the same thing would be applied in that piece.
Good. Anybody else?
So you're basically telling them it's not a 9-to-5 job, kid?
Yeah. So then, how could we prevent this? Kind of like Shelley mentioned, set your expectations up front. Yeah. Good. And then, how would you give feedback? So Stephen kind of talked about what he would do. Would anybody do anything different?
Open it, so tell me how you think yesterday everything went, and see what they say. And then it makes them more self-responsible for assessing.
Yeah. That's probably what I would do. I'd probably have them tell me what the request was, and was there a patient tied to it, and try and get them to realize how the patient may have been affected by them not following through, and kind of allowing them to come to their own conclusion, like, oh, that probably wasn't the best way to do it. And then have them self-evaluate, and then discuss how they can learn from it, hopefully. Hopefully they get to that situation. But if that maybe didn't work, I'd probably do what Stephen did and say, I had to do this, you drop the ball. Be direct with them. Okay. Any other thoughts on this one? Okay. All right, next one. It's 4 weeks before the start of your Block 4 API rotation. Your student emails you to ask you what they should do to prepare for your rotation in a heart failure clinic. You provide detailed information, instructions, resources, and make your expectations clear. So we learned from our first scenario. The student shows up on the first day and is unable to tell you the drug classes used to treat heart failure. So they obviously did not prepare. How would you handle this? How many of you would kick them off, tell them to go home that day? I would.
I think I would ask, what did you do?
Yeah.
Like, I mean, maybe they got emails confused or, you know what I mean? I'm gonna kind of just, but yeah.
Maybe give them the benefit of the doubt.
Or say, I'm sorry, you're not ready.
Mhm.
For whatever reason you gave, this is what I need you to be able to do. So go today and do it.
Good.
I'm more of an up the ante thing. Fine, you didn't know it? Cool, you get to tell us all about it tomorrow.
Good. Would anybody do anything different? What's that? Time out. There you go. Go read. So how could we prevent this? We've already set our clear expectations.
Maybe having them complete like a pre-rotation quiz or something before they come in.
Oh, good. Yeah. She said do like a pre-assessment, pre-rotation assessment to get a idea of their baseline knowledge. Is there anything else you guys can think of? So then how would you give feedback about this?
Why'd you send me the email? You didn't want me to follow through.
Right.
And then I know the response is going to be that, well, they told us to do that. And don't do that.
Yeah. And I'd probably follow that up with, and I told you to know this stuff before you came. So this scenario kind of violates the commitment to excellence tenet that we talked about. So we've kind of already talked about it, but yeah, I would tell them, do a lot like what you said, Shelley. I would say, all right, you're not qualified enough to be here. Go home, learn about this. We'll talk again tomorrow. But this hinges on, your rotation hinges on this.
Send them home, and that's actually a reward. Versus you
Well-
send them to the library or someplace that's a.
The immunization room, yeah.
That's much better.
Yeah. Well, I guess they have to do something, because if you tell them tomorrow you're given a topic discussion on this, you better know what's going on. Okay. Last one, you have a PGY2 pharmacy resident on rotation with you, and you're comfortable enough with their knowledge, skills, and abilities to allow them to work independently. The main physician you work with discuss their plans to change medications for a patient, and the resident tells the physician that their plan is wrong and should listen to them instead. So this one violates the respect for others and the professional presence, and this reflects poorly on you. So how would you handle this?
I just had this with the student last week. It was a long, heartfelt discussion and then actually practicing scenarios. It wasn't easy. They couldn't understand why it was a problem.
I think it's a lot, and not just from students, but from other pharmacists too, not recognizing that it is a relationship. And I don't tell my husband, you did the laundry very wrong, and my stuff shrunk. You know, like, I don't say it in that tone, because, you know, I have to live with him every day. You know, for one, I want him to keep doing the laundry. So, you know, you have to really use tact when you're addressing that, because the difference of opinion
Right.
is respect for others. Like,
Well, in this case, with this one student, they're like, so you want me to lie to them? I'm like, no.
no.
I didn't ask you to lie, but I did ask you to have respect and appreciate the fact that they've got background knowledge that you
Right.
can understand. And yes, you may be right. But you gotta figure out a way to communicate in such a way you don't tick them off.
Right.
I think a heart-to-heart is probably how I would handle it. Like, have a real heart-to-heart about how, at this point, you have a responsibility to communicate effectively. And that's not the way you do that.
Right.
Maybe let them come up with some alternative ways of phrasing their recommendation that would not undermine that prescriber's authority.
Good.
And, you know, like, give them the chance to, you know, say for themselves, because sometimes you get put under the gun and it just flies out. You know.
Common sense.
Right.
Yeah, it's maturity.
Right.
So like what she said about giving them a chance to give an alternative way how you could say it, make them think another way. Because some people are just like me. I'm kind of like that in a way. I'm blunt. And so I spent my whole career trying to figure out the right way of saying and approaching things. I'm not this blunt. But yeah.
There's a time to be blunt and a time to appreciate the fact that the person you're talking to, in all cases, maybe you're superior with regards to patient care,
Oh, yeah.
because they're the team leader, and you have to appreciate that. You may not agree with it, but you have to appreciate it. And that doesn't mean that you give up patient care for their ego, but you need to be tactful, otherwise it's a total shutdown. Yeah, this student still
Yeah, they
didn't
won't
get
want
it.
to work with pharmacists.
Right. Exactly. So what could we do to prevent this from happening?
This scenario is tough, because this is, you're saying a PGY2 resident, which means it's probably not the first time it's already happened. So
Right.
They may have missed, you know, feedback in the past, or the resistance.
Do you think there are times that we need to teach people to have good enough judgment to say when there are times that you must put your foot down because the patient will be harmed? Not that you don't agree, but that the patient will be harmed if that occurs. You see what I'm saying?
I do.
I think you can do that, but there's also more tactful ways of saying that.
Yeah.
Well,
Jane Connie and I'm sure I've refused scripts before and said, no, I'm not filling it.
Yeah.
It's not safe.
Learn the hard way,
Yeah.
unfortunately.
Mm-hmm.
Like you said, it's probably not.
Right.
It's happened before, that's the person, it's part of their personality, so they're.
Right.
They're gonna have to go through something very unpleasant and difficult before they finally get it.
Right. So what you could do, and what, if it happens, this is probably what I would allow to happen, is let them just reap the natural consequences of that physician coming back at them and saying, you don't know what you're talking about, or whatever they might say. Let them feel that, let them reap that consequence, and then maybe they'll never do that again.
You have them go to the prescriber and apologize.
Oh, yeah.
That's,
Kind of say, because I think, eating that.
Oh, yeah.
Pie,
Yeah.
sometimes are really good.
Oh, yeah. Yeah.
I love it.
Yeah, you could definitely do that.
I think as a PGY too, it can be pretty difficult because they've got this knowledge base now and they understand that they do know things that can make a big difference, that decisions are sometimes wrong. So that's a heady feeling.
Right.
To know that you can be right about something like that. But then they haven't had the long-term experience to know what it takes to develop that relationship.
Right.
That's, part might be helpful, but it's not.
Yeah.
I can think of a couple that were even in your class.
I was actually thinking about it.
But I think being burnt, like what she was talking about, might in this unique situation have it occur, and matter of fact, give all rights to that physician to just.
Depends on the physician too.
Yeah.
Huh?
Depends on the physician too. Like if it's Kenny and Molly John, that's like a whole different thing than another scenario.
Yeah, good point.
So have these things ever, has student ruined the relationship with the attending? They sort of understand.
I've had it.
Because I've known my attending since like 2012, it's a lot different. But I've had a student who was talking about, I think it was heart failure, and they're talking about heart rate target, and it was absolutely wrong. And the doctor was like, I don't think so. And the student was like, yeah, it's this. And it was like they were almost arguing with them. So there was that awkwardness, and then I kind of I talked to her, and then I had the student go talk to her later, kind of like what you were saying, like, hey, I was wrong, sorry. So it didn't ruin it, it was just really awkward.
I got chewed out. I literally got chewed out by the practitioner. They were angry because the student answered the phone. Yeah. I mean, it was George. And in fact, I think he was around whenever you were there. He had his feet up on the table in the
So I think part of what we could maybe do to prevent some of this is a lot of us have long-term standing relationships with our providers, so you could say, no, you're wrong, or you can't do that. I find myself saying that a lot. But I tell my students or residents ahead of time, this is a relationship that I already have. You don't have that. It doesn't translate to you. So you have to watch what you say, and here's how you can be strategic about it. And I let them practice with me. But I try to get them to recognize, sometimes I'll do this if I'm trying to put my foot down about something, but I have to be strategic, and it really depends on who it is. So kind of explaining that up front, what your relationship is compared to what theirs isn't, could potentially help prevent some of this too, and kind of setting the idea of what they can expect. All right. So we talked about the feedback. So quick summary on professionalism. There's multiple definitions for professionalism. It's not just how you look, but also how you interact with others, how you present yourself. And some keys to success are setting clear expectations early identification of issues and addressing them right away. So don't wait till the final evaluation of the rotation to say, hey, remember during week 1 when you told someone they couldn't do something? That's probably not good, because then they missed the next 4 weeks of potentially fixing that and improving. And then consistency of evaluation. So is there a general agreement on what the expectation is? So when you're evaluating somebody at below expectations, what does that mean? Or above expectations, what does that mean? So here's my references, and if there are no questions, I will pass this on to Jane.
What is professionalism in akin to emotional maturity?
That's a good question. So I think that would have to do a lot with respecting others' opinions, and demonstrating empathy and those types of characteristics respecting others' opinions. Do you want to hook yours up or just use mine?
Okay, well, I'm going to talk about the communication piece. And I feel like the communication is the integral piece to this whole process. Because if you can't communicate effectively, then it all falls apart. That's a key for everything, for life in general. And so to segue from professionalism to communication, I'm having a couple of students this semester. They start their rotations on Monday, and I've found out 2 students that have not communicated with their preceptor at all. So they don't know when they're supposed to start, where they're supposed to meet, or anything, too. And time again, we do it in orientation. I send out emails. I've sent out like 2 or 3 emails, like, get ready for your rotation. And they just don't communicate. And I feel like this generation, like in my day, we used to talk on the phone for hours at a time, you'd actually go on dates. And now everything is, social media, texting. You probably have, if you have teenagers, they'll sit in the back of the car and they don't want mom to hear what they're saying, so they'll text each other and they're right in the back of the car. So these students are not brought up communicating face to face, so I think that's why they have some issues. So we talked about the pharmacist patient care process, and in every area of this process, communication is a big piece. First of all, the data collection. This is where you're getting the information from the patient, so you have to be able to communicate on the level with the caregiver. It could be a healthcare professional. They need to know what level to communicate to get the appropriate information. The information evaluation. Well, they have the information, they're looking it over, but they might need to call the lab and ask for additional labs. They may need to call, if they have a home health nurse, call and get some additional information. Call back to the physician's office. So there's communication involved there. Formulating a plan, they need to communicate back with the patient, because if you're going to make a plan, you need to have the patient involved for them to agree to do it. So that's more communication with the patient. Maybe they can't take a drug. I'm not going to take it if it's a every 6-hour drug. So you might have to communicate with the physician to see if he can have an option to maybe use a twice a day or once a day antibiotic or such. Then implementing a plan, that's where you have to go into your counseling mode. You have to be able to explain to the patient to get their buy-in to actually have your outcomes, your positive outcomes. So everything is tied to communication, and appropriate communication assures the positive outcome. And then the monitoring and modifying the patient. Even in retail, in the hospital, you can look at their labs and maybe go in and talk to the nurses. But even in retail, I'm sure when Mike knows his patients and they come in and you say how you're doing on your blood pressure medicine, or how's your blood glucose levels been, that's actually monitoring and making sure that you have a positive outcome with the process. So I'm going to go through the different domains, and I picked out the pieces that are directly related to communication. And for patient care provider domain, taking a medication history. Well, that's communication right there. And once I said before, you have to get down to the level of the patient or the caregiver to get the appropriate information and a correct history. Patient assessment, they can do, these are activities you can actually have them do that you can assess, like a patient assessment of blood pressure, pulse, respiration, temperature. You could have like a little health fair in the front of your store, or we do a lot of health fairs here, so students get to do that. I don't know in the hospital if you would do that much, but maybe you could have an employee health fair where they could practice. Prepare a note documenting the findings and recommendations and plans. So this is basically our SOAP note. That's a form of communication. It's a written communication, but we want to prepare and have them do these kinds of things when they're on rotation, so they'll be ready to do them on their own when they go out. And then educate and counsel patient, and that is through every area of pharmacy. We need to be able to educate. So for the interprofessional team member domain, these are some things that we can use to assess their competency, is contribute medication-related expertise to a team. So this is where they have to answer a question like we talked about with the professionalism, and professionally relay the information to the other healthcare professional that had the question. They could be in a like a journal club, and they have to answer questions in there. Justify recommendations to the team. So I think when you're in a team-based atmosphere, and that's where you need to bounce things off other people in a professional manner, but you need to be able to do it in the right way. We just had the whole discussion on there's right ways and wrong ways to say things, and I like the idea of when you come back from one of those meetings, maybe talk with your student about what would have been a better way to say this, or what would have been a better way to do that. Another way you can observe your student explaining to a patient, caregiver, professional colleague, the members of a team. So maybe, like, if you have a patient that comes in and they're going to be a team that sees them, then maybe they could explain, well, this is your physician, and you know what he's going to do. The nurse is going to do this, just so the patient would know. This is just one of the ideas of what you could do to assess their competency in these areas. And then watch and see their appropriate communication skills when interacting with the team. So that's pretty obvious there. Things you can do for the population health promoter domain is perform screening assessments. And this is, again, they could do blood pressure screen, diabetes, depression screen. And these could all be like at a health fair, or just administering to a patient in a hospital, like doing one of those depression screening tools, but you're interacting with the patient, so that's communication. Administering immunizations at your local pharmacy. You could have like a flu clinic and let the students interact with your patients as they come in, fill out the forms, counsel them on the immunization and administer it. They can set up a health fair. To coordinate something isn't just talking to one person. You have to talk to multiple people to actually coordinate the activity and get it to be successful. Okay, other activities under the information master domain. These are activities that you can use to assess their communication skills. Is a lead a topic discussion, participate in a journal club, prepare and deliver a brief educational program. All these require that you be able to communicate successfully. And so some of the preceptors in the room, and do you guys know how to get into your preceptor, pharmacist letter preceptor toolkit? Because I'll show you guys, I don't know that everybody does, but I'm going to show you how to get in there. They actually have journal clubs that you can do. It has questions you can ask, and it'll make it so easy. You don't have to come up with all these things on your own. They also have like topic discussions you can do, and it gives you your key so you know all the answers. And so these are things you can do if you have a P4 and you think maybe they need more communication, have them do one of these things so they're communicating back with you. Okay, for practice manager domain. This will be where you might have them supervise technicians or other support staff in the pharmacy doing an activity. So they have to communicate with their support staff while they're doing that. So that will be a way you can assess to see how they handle and supervise. Because I'm sure everybody in here has seen someone who got a little bit of power and they go crazy. So that would be a good opportunity to see if they understand the limits and how you treat other people when you're trying to teach them something, or you're coordinating their activities or supervising. Assist in training nurses, technicians, and other support staff. So if you have an in-service that needs to be done up on one of the floors, you have a new drug coming out or a new pump they need in-service on, let your students do that. That's a good way to assess their communication. And obtain authorizations for a non-formulary medication when clinically appropriate. This is basically call an insurance company, call the physician, find out they need a pre-auth, and then maybe you have to call back to the insurance company. So that requires a lot of communication too. But these are things that fall under that domain. Then we have self-developer domain, and this is more written communication for them to make a written plan for continuous professional development. So there's not a lot of communication with other people on this unless you work with them to help them develop this. But that's something they can use. But that was sort of communication. So I just wanted to show you how communication is involved in every one of those domains. So now we'll have some scenarios. Scenario 1. Julie is a P2 student. I picked the P2 because I do the IPPs. And she asked if she can set up a table in front of the pharmacy to advertise flu shots. After your approval, she sets up the table with appropriate patient information and then sets up the counseling room with the VIS statements, consents, and all the supplies needed. And by the end of the day, the pharmacies provided patient education and flu shots for 30 patients. So what do you think about her? She's a go-getter. So I sort of did this a little bit differently. I'm using our tools, our assessment tools that we have. And I just wanted you to look at this and see where you would rank this person. Remember, she's a P2.
Yeah.
As a P2.
All right, Stephen.
Just say 4.
You say, oh, you don't give fives. I mean, he never gives five. This is a P2 student. She came to you and wanted to do something extra, and she set it all up, and you didn't have to do anything. She is a 5. But anyway, I just wanted to show you what a 5 might look like. It's somebody that goes over and above, I think, what would be expected for a student at that level. So everybody but Stephen agrees she's a 5.
Yes.
I think,
I was going to give her a 4.
Were you really?
5's like going out to the highways
Good Lord.
it's not
radio program.
I think compared to some of the students that we have, she was a
More than
All right. All right, Mike, what do you think?
What more does she have to do to earn 5?
I would say advertise it beforehand and really try to like make it more of a health fair event where it could be like more to it. I mean, it is a good thing.
Was the pharmacy planning on setting up the table to like advertise, or was that like her idea?
Well, it was her idea to put a table up front, advertising health fair, you know.
So that's something that I didn't even think about. I mean, that's really.
Yeah, because I think
That's,
when I wrote this up, I thought that she was thinking it's October. I'm going to help Mike out, and I'm going to say, can I
If
go?
she comes to my pharmacy, she'll get sick. I'm telling you, that's going beyond.
Okay, so basically, I think we've consulted as a big group, and the feedback would say, Stephen would say, well, you need to get out on the radio. You get on the radio. So, any comments? Or she didn't really have any perceived deficits, except she didn't do enough marketing. But
Not a deficit, that's.
yeah, so I think she's pretty good. So I've got now. I thought I'd start out with someone I thought was at a 5. Okay, so Brian is a P4 student on his 3rd rotation. So this early in his P4 year. You're his acute care preceptor, and you have assigned him to present a patient to the infectious disease team. While preparing the presentation, he comes to you for guidance in the formatting, how he wants to set up the patient presentation. He does the presentation, and it was well received by the team. He was able to answer most questions without your assistance, but you had to help him some on his, during the thing to help answer some questions. So where would we put this guy?
3.
Everybody votes for a 3? I think that's probably right, because he did have minimal assistance. He's early in his rotations. He hasn't done a patient workup yet, so he really didn't know, so he wanted to know what you want.
But it didn't embarrass you, that's all that.
Exactly, that's the main. Okay, so what kind of feedback would you tell this gentleman to make it better the next time?
Anticipate questions that you might ask.
Answer specific.
Anticipate questions.
Right, and that's what I always tell students too. When you're going to make a recommendation to a physician, that's what I would always do. I think, okay, he's probably going to ask me this. Anticipate, that's really good. Anticipate any question that they might ask and be ready, because that's when you get really embarrassed and I start stumbling.
I've had a lot of students, and I'm still kind of thinking of my own experience, like early on in APPs. I felt like I struggled knowing what might be asked because I hadn't had much experience making recommendations in certain areas, whether it be, ID or, something that maybe I hadn't studied as thoroughly in school. If they can't anticipate that, like kind of helping them find direction as to who they might ask, like, what kind of questions do you get when you give this kind of presentation, so that it's not like all on them to come up with some of that, because I don't think they really know.
That's good.
And I don't want them to be blindsided once they get there.
So start
Is
with
that unreasonable? Like,
Did you hear what she said? She just said that she, you know, when you're a P4 student, you might not know what questions to anticipate. So she recommends guiding them to, like, where to go to look and find out what questions they might ask, or another person that has done presentations and they can tell you basically this doctor usually will ask you this or that, you know, like sort of do your groundwork before you go into that situation to help you be prepared.
And that's it, they're this early on, you're that concerned about like a practice or like a great idea.
Right.
Especially if it's to a team, it's kind of high stakes.
But his communication skills was good, you know. So he got it was well received. Okay, so this is the third one. Roy is a P4 student on his 4th rotation and is scheduled at your ambulatory care clinic. He was assigned to work up a patient and write a SOAP note to place on the patient's chart. You review it before he goes on you review it and you're shocked that it has so many errors. The content is acceptable, but there are many spelling and grammatical errors. You're on a tight schedule, so you redo the note yourself.
Yeah.
Yeah, everybody agree a 2? Yeah, that's a 2. And I would say there's a thing called spell check, and but we run into this a lot, and I hear a lot. Our students can't write. I see it. It's very disappointing, you know, how they get to this level, and they don't use proper grammar.
Some of them get their grammar a little bit confused just because English is secondary to them. And I'm not even
And I know,
sure-
and I don't know how, I guess that was the overarching question is how do we approach those students that do, maybe English isn't their first language, and, you know, it's amazing that they can even make it I can't imagine going to another country and trying to learn in a different language. You know, they're amazing, but somehow we need to get it because the doctor that's going to see that note isn't going to understand it. So we need them to communicate better
I
on
would think that there's some sort of a program out there that would do that for them. You know, that they could do a double check on for them, for this kind of stuff.
There is stuff out there. I think one of the issues we run into after meeting with Allison quite a bit from Academic Success Center, if students are English second language, they pass the test and all these things, you know, we can't mandate, we can't force, because we basically said you are, you know, efficient in communication based on the test scores that they should be.
So you're efficient in communication for everyday life, but when it comes to prescriptions and medical information, it's absolute.
I know, but
You'll excuse me, but I have issues with their center over
But
there. On that
it's not
side.
that, it's not that, that's laws. Those are laws. Those are not, you know, they're not our policies and stuff. I mean, legally, you
I-
can't do anything
I
about it.
understand that, but are we not held to a higher level as practitioners? Because we take into account not just our own safety, but more so everybody else's safety. So it's my responsibility to be a better communicator, better than what even the laws provide.
I agree.
And I think in this example, we all agree 2, right? And I think that this is one where we don't want to be afraid to get a 2, because then that student kind of has that red flag from somebody else outside even of the classroom, which to them I think is more meaningful to say like, I've got some deficits here, and hopefully we can help them correct those things without.
They
What-
don't want to give out this information, but they need to be directed as to where to find it.
So what I usually do, and I'm sure I've seen you guys do it too, I'll take a note and I'm just like ripping it up with the track changes out to the side. Sometimes they go longer than the page. And I'll send it back and say, this will be on a reflection for one of my rotations, but I'll just tell them, you know, I'm sending this back to you so that you can read yours and compare it with mine, and to help them to learn. What really bugs me is when they don't capitalize the word I. I've seen, that just drives me insane. I don't even know how spell check doesn't pick that up, but I've seen that multiple times. Or another thing is staffs, S-T-A-F-F. they say staffs, and see spell check won't pick that up because it's a plural word, so I always have to send them out and tell them it's like the word sheep. It's like, but anyway, so hopefully I've picked that one up before they get to you, but that's one I see a lot.
Well, the worst writer I ever saw is now a critical care guru, who still can't write to this day, so. He can write orders, but he can't write a paper.
All right, does anybody else have a way to help this person?
What I see a lot of with students especially is their notes are just too wordy, and they take way too long to say what needs to be said. And I think just having them like pull different examples, even like review, 10 or 20 patient charts and pull examples from notes you like, don't like, and why, and kind of help them trim it down to, because some people are really good at expressing things. And I steal, I beg, borrow, plead, whatever, to get some of those phrases that you're going to use all the time.
Well, I think it's part of it. We're teaching them how to write SOAP notes, so we want them to have all this information, and we know it needs to be more succinct on the real patient's chart,
So
but
why are we teaching them the way they really need to do it on rotation? This is my
Because we
biggest.
have to learn how to think.
We can't
That's
assess
fine.
And then we have to
They
assess
learn how to
something.
think, but then they need to learn how to communicate what is being expected of them. I hear the complaint from the students all the time that you guys taught us this way, but we get on rotation, we get yelled at because we didn't do it this way. We've
We
got
get-
to show both.
We give feedback, and it is part of our rubric that we use to, if they're excessively wordy or something, I take points off of that all the time. And I'll rework a few of their sentences, like you can say this same thing in this amount of words, so I do get feedback on that specifically.
There's a difference between ways you
Frankly,
practice
from-
too wordy
yes,
and
yeah.
on the soap note.
I appreciate you doing SOAP notes the way that we were talking here, long style, because this is the only place you're going to get that. And it does help formulate your thought patterns, and I think it's important that they know the difference between what you're going to put in a medical document and what you're going to keep for yourself on that issue.
But when do we teach them how to do it the way most institutions?
I think the problem with that is, though, I've been at 3 hospitals, and all 3 of those do it differently. And so every place has a different system of
But
process.
have you ever seen a place where they do it several pages long?
I think they do it in clinics, but I don't know.
No,
No,
one says
I try, it's more important to keep it concise because even in the ambulatory care clinic, yes, I do have a little bit more wiggle room, maybe a little bit longer, but I can't make it that long because compared to my provider's notes, I'm lucky if they'll provide an explanation of why they make a change.
Okay, well, we'll wrap up the communication and we'll turn to the
No, I think you brought up that good point, Shelley. I think you really brought up a good point about.
It's frustrating to
Yeah.
them.
But if you guys, especially on the midterms, if you can identify areas where there are weak, like in communication, then we can try to do things to work with.
Yeah, I take no issue with how it's taught. What I take issue with is the fact we don't also teach them what they will see. And that this is, okay, so we've taught you long style so that you can get your thought process together. That's why we're doing this. Now, when you go out and practice, this is what they're going to be doing. This is the reason why they're doing it that way.
If it makes you feel any better, I just talked to a pharmacist that works at a hospital, and he is currently doing his bachelor's to PharmD, and he was telling me, he was complaining about that same thing. So Shannon Doe is teaching the long method. He goes, and I work in a hospital, no one ever does this.
No,
But
Any more discussion about that? All right.
Short note though, just sorry.
Oh, no,
The
you
short note says, I know what I'm doing, I'm only picking out the pertinent, get in, get out, explain it, move on. It takes 3 sentences.
And I think students can learn that on IPPEs and APPEs, like during a time and a process, so they'll be better at it when they graduate.
That provides them those different
Settings, too.
And I think if you're picky enough about it, like maybe, that's some of the background information we can include is, hey, these are samples of the notes that I would like to see, a general
So I'm going to talk about self-awareness. It's nothing, I think we all have pretty good self-awareness, everybody in this room here. But when I'll get through a lot of the topic, it seems to be more of an issue today than it probably ever has been. And I'll talk a little bit about the evidence behind that, not much, but we'll get into that more. But specifically, this comes from the ACPE 2016 standards, the CAPE 2013 outcomes, and 4.1 is self-awareness. And basically, a graduate should be able to reflect on themselves, think about themselves, do metacognition, and really say what I can get out of myself and improve on. And so some basics to that is they should have personal knowledge, skills, abilities, and biases that they should be able to reflect on, and have motivations and emotions that they can also reflect on. I'm really going to focus on personal knowledge and skills and ability, and then talk about one of the issues that kind of flow into all of these at the very end. But everybody should be able to reflect on these and improve them in some form or fashion through professional growth. So when we think about self-awareness today in our students, we usually think about, unfortunately, the decline in... Oh, that didn't go. Man, there we go. The decline in self-awareness. So I would say the majority of students I deal with, no matter how good they are in the classroom, how good a communicator they are, they lack self-awareness. And it's hard to really coach self-awareness. Despite that, I personally think I'm observing a decline in self-awareness. There's actually little to no information to suggest this actually exists. One reason is because you can't actually do a retrospective study. You can't really do a prospective study because we're talking about generational changes. But it again comes down to probably technology that has a lot to do with it. I'll talk a little bit more the next that really factors into it. But basically we develop these opinions and theories about generations. And right now with the millennials and whatever the next generation, I don't know what they're calling the next one now, but we generally will say that they have a lack of self-awareness. It's hard to really get this subjective observation off our minds, but that's kind of like where we're at because we don't have a lot of evidence to say this is happening. What we need to do from a precepting standpoint is don't dwell on that issue. We can't change an entire generation as one professional organization, one professional body. Even the whole field of medicine cannot change what we perceive to be a global problem with a generation. I don't know how many of us are from the millennial generation, so there are individuals that should be able to be very self-aware. Focus on that individual student. Don't focus on, again, the whole population. See what you can change with that student to help improve their self-awareness. And again, improving self-awareness is going to be extremely difficult because there's a lot of factors that can influence their self-awareness. The first one from a standpoint of, I'm going to speak more for APPEs or postgraduate training, is their previous feedback. There's nothing like telling a student, you're not aware of this, or you have a deficiency here, and their first response back is, everybody's told me I'm awesome. That's been their feedback for years and years and years. Nobody has said this is a deficiency. And as a preceptor, you might have to think, maybe it's not them, maybe it's just a task or something like that. But having that barrier to feedback because everybody's already told you you're awesome is very difficult to overcome. Then we have social environment. When I talk about social environment, we're also talking about their upbringing. Unfortunately, everybody gets a blue ribbon for running a race. Everybody gets a trophy for participation. That's a hard thing to also overcome. For me, I always tell the students, like in our orientation the other day, there is no A for effort. And that is a hard thing to instill in a generation that has been given an A for just attempting, for just showing up. We're out of that now. Going back to what Julie was saying, it used to be APPEs were more an observational thing. Now there's tasks and outcomes tied to them that you really have to intervene with as a student. And so now getting that environmental aspect out of their mind is very difficult. The other thing with social environment is their friends, their family, and where they stand in those circles. For example, if you have a leader in one group and you put them in a scenario where they're actually having to be a leader again, but they don't lead because it's not their comfort zone or it's not that area that they've been working with, that's a very hard environment to overcome as well. So it's not just about, you know, how they were raised, it's also about the group that they hang out with and friends and everything. Then academic success. I hate this one the most, probably because it comes back to that concept of how do you tell a student who's not doing well but has always been successful? There's nothing like having that A student, that 3.8 GPA, that 3.7, almost that 4.0, and they're a terrible performer on APPEs. And then that's their barrier to feedback is you're being too hard, you're being too critical. No, that's not right because I was an A student. I did good in class. I performed well. This is something I feel like at least I deal with this 1 or 2 times a year, every year. And they're not aggressive with that feedback restriction, resistant to feedback. But it's just hard to overcome that, to say that you're not as good as you think you are in this aspect. And so going and opening up a book is not going to fix this. It's going to take you to actually make some soft observations about yourself and making some hard decisions about how to overcome that self-awareness barrier. Then mental health. So mental health is multifactorial. It can be stress-induced. It could be organic causes that cause mental health problems. And then, of course, you have just a mental health issue as well. You can also have substance problems. There can be a lot of issues surrounding mental health that we haven't usually encountered before, that we do encounter a lot more often now. And you have to be very sensitive to the mental health barriers when it comes to self-awareness, because it's hard to tell somebody, hey, you know, you're slow to respond in this, but they're on a lot of medications for anxiety or depression, and that might be influencing the pace that they can work at. Then we have developmental disabilities. And my last scenario really plays into this. Unfortunately, with the developmental disability, some of these people can be very high, again, academic achievers, poor communicators, poor self-awareness, poor teamwork, poor integration into a lot of things. So that becomes a very big problem when you're looking at professional competencies. So the first one I talk about is personal knowledge. And kind of like thinking about what a baseline knowledge is. So students should have, in my opinion, students should have a baseline knowledge in major disease states when they come to rotations. That's one of my expectations. Core rotations should be able to assess these in different aspects. For example, I am not going to assess somebody's knowledge of diabetes. And if a student tried to assess my knowledge, I'll show them how embarrassing I can be with my knowledge of diabetes. Because I don't treat diabetes. I only treat hyperglycemia in the hospital. I don't take care of those issues. But, you know, they have to have that knowledge as a student. I have a different knowledge base than they do now. The tool book for ACCP that I think they started doing it in 2012 and they updated, I think the last one was 2017. It's a great toolkit if you haven't looked at that. And I have actually, when Rachel divorced the school and went to be a stay-at-home mom, I totally changed the way I had to address the rotation after we had a subcommittee to come up with this new evaluation tool, because I said these are things that I have to be able to assess in my students. When a student leaves my rotation, they should be able to manage hyperglycemia in the hospital. They should know anticoagulation, DVT prophylaxis. But I left some big things out where students may struggle, such as infectious diseases, because not all students are going to be strong in that. And if they're only there for 5 weeks and their first job out of school might be at a small rural community hospital, they don't have to be proficient in infectious diseases, but they should know how to dose vancomycin. They should know that drug. They should know kinetics. So I took away the whole global aspect of just patient care, and I tied some objective tasks that I could actually evaluate. And then I still give them that 1 or 2 patients to follow comprehensively, but they look at a lot more patients and get now exposure to more disease states. And improving self-knowledge or personal knowledge can be very hard. Going back to that student who is awesome in the classroom, but then when you really are assessing them on core components and they're lacking that knowledge, they may reject that feedback quite a bit. The other thing is the student becomes depressed. You shut them down by giving them hard feedback. And, students need different types of feedback, just like we give different types of feedback. Some students need it hard. Some students need a little coddling. It's, again, where we have to change our approaches. But for me, I'm always going to be that person that's like, this was bad. This was terrible, and you've got to do better. I will coach them, but that first thing, I'm probably going to make sure that they realize that this was not a good approach to something. The communication barriers that students can develop has a lot to do with the academic success and as well as their depression state that you may send them in with their feedback. So that communication is, I'm done talking, and it's a total shutdown. They get angry, or they may just go ahead and from that standpoint not want to be on that rotation anymore. That's hard to deal with. I've only had to deal with that really one time, and it was because the feedback that we were given about personal knowledge was a recommendation they brought up, and the recommendation was wrong. And that student the whole time thought I was really critiquing them on a communication aspect, and it was not. It was their personal knowledge. So they didn't want to bring stuff up in front of the team anymore because they were embarrassed. I can't help with those emotions or some of those feelings. You have to overcome that. And that's, again, what I kind of coach them, being comfortable in uncomfortable situations. I tell them every day, if I have to counsel a patient, I'm never comfortable because you never know what they're going to ask you. You can always be prepared, but it's always going to be an uncomfortable situation. There's nothing like trying to tell the attending physician, this recommendation is not, and you got to do it very tactfully, but this is the actual standard of care, and this is the evidence-based medicine. And to do that in front of a group of people, that's never going to be comfortable, but you have to be ready to do that. So giving those feedbacks can be very difficult, and especially when you're addressing somebody's knowledge base. That's a P4. They've done all the didactics and they made it. So they should have a good knowledge base. So here's my scenario. I have two P4 students, and this, of course, is a real scenario that I probably encounter multiple times a year. Two P4 students come to a heart failure discussion with me, and both students failed to identify etiologies and provide comprehensive description of the pathophysiology. They both identify appropriate guideline-directed therapy, but one student outperforms the other in terms of they're able to apply this in different clinical scenarios. Like this, what are you going to do if the potassium's this? One student could say, oh, that's easy, we'll stop the ACE and put them on hydrolysine isosorbide. And the other one's just like, sounds great. Because they don't have a clue where you're going with this. So how would you approach the student's performance?
During, I would, if the one student consistently speaks up and has the right answer, I'd probably direct my questions to the other one and say, okay, what do you think, before allowing that person to answer so they can't piggyback off of the other one.
It's hard because they love to do it.
Yes, they do. Mm-hmm. Especially during the discussions, and one student gets that first line therapy and then you pick on the other one. They're like, well, that's not fair. I mean, you got the first line, but you got to know all of it. What else? So this is where I usually set students up, I don't know how to say this. That first topic discussion, which is usually not heart failure, I usually set them up for failure. I do think it's important to put students in environments where they will not succeed, because there's going to be many of times they won't succeed in whatever they try really hard in life. And so the in-depth topic discussions that I have with them, if they don't prepare for 5 or 6 hours for that discussion, they're probably not going to make it through. So a lot of times they go home, look at some slides and everything, read through some bullet points and the guidelines, and then when they come and they can't even get through the etiologies. What causes heart failure? I don't know. Like, they can't even get to therapeutics, because that's all they focused on was the drugs and what works and stuff, but they didn't get the background information. So I usually cut it off, just like that scenario of the student wasn't ready for first day, and I usually say, hey, you're not ready for this. You all go back home, and now you know what you got to do to be ready for this discussion. And this is usually well received, because there's nothing like bearing out a discussion for 2.5 hours when you don't get anywhere. In this situation, I talked to them both as a group and said, you both are very bad in the etiologies and pathophysiologies, which means that they really don't know the pharmacology of the drugs. That's how I spin it. But then I usually give them 2 separate feedbacks, because then you can start getting into more personal things and telling one student, you know, you did do good here and great with the clinical knowledge, and then the other one I'll tell them, you know, you were very outperformed by the other student. Consider like where you need to go in further development of your knowledge. And so giving them specific areas that they can improve on. Heart failure just may be somebody's bad topic. Might be. And you got to think about that. So that's where I say, is this a bigger issue, or is this just failure on one observed task? So I think that was great how Jane had us go through all those grading. You know, all those grading comes up at the middle and the end of the rotation. But if you think about that on observed task, it can help you develop that grade a lot easier at each of those evaluation points. The next part is the skills and abilities. I put these together. You have to really establish expectations on the performance level on day 1 of the rotation. I tell the students I expect them to remember everything they read, saw, and heard in pharmacy school. And no, I don't really, but if I give them that level of achievement that they have to meet, then maybe they will. Maybe some say, well, that's not possible, so I'm not even trying. You know, that's not a very professional thing to do. But trying to give that big expectation. Also consider asking students, you know, what are your expectations to get out of this rotation? And what can you do to basically improve your self-awareness or your abilities and your skills? If I ask a student to do, you know, give me what their expectations are, do not judge those expectations. You know, if a student says, I need to improve on this, it may be something very simple, or it may be something more complex. You have to realize every student's at different levels, and they have different strengths and weaknesses. And so don't really be discouraged, and don't judge that expectation that they give you. IPPEs and APPE student rotations are a time for learning and not just for assessment. I think we have forgotten that a lot of times. APPEs is not just a testing environment for the real world. So these students are still learning. So going back to the SOAP note writings and stuff, this is a time to teach them those skills that is hard to teach in a classroom. And so using those and all those contacts with those students to really teach those application and not just the didactic information. Then start using your skills in Preceptor. Instruction, coaching, facilitation, and modeling is very key. And so coach the students on how to improve their performance. Set the goals that both you and the students can agree on. And make sure they're achievable and measurable, as we've already kind of talked about before. Now I'm going to jump straight into a scenario for disability, developmental disability that I have unfortunately seen more recently in APPEs and postgraduate training. So in this scenario, we have a first-year resident that comes to the rotation after several years of professional experience and has great academic success. From the first day of the rotation, or the learning experience, the student or the resident fails to meet deadlines for topic discussions. They're rarely prepared for rounds. And you notice that they have a pretty good baseline in clinical knowledge, but applying that directly to patients is kind of difficult. Other things that this resident displays is they don't show a lot of emotion or disappointment to feedback that you give them, despite it's very critical and hard. Just more of acknowledging, yep, I know, and just kind of head nods. Despite consistent and repetitive feedback, all the same behaviors are repeated. Works really hard, but fails to meet my expectations. Thoughts and ideas are rarely organized. And the dress and interaction with others is usually professional, but it's not really socially appropriate. Such as, you know, during rounds, the resident can, and students in these scenarios, you know, interact okay with people in terms of the knowledge base and trying to bring up recommendations. But you say, you know, talk to them about this, but not this. And of course, they just go on all these tangents, you know, talking about the color of pills or, how to infuse a drug when that's nothing to do with what we're talking about. And then, of course, bringing up other things like, what's everybody doing this weekend, what did everybody do last weekend? It has nothing to do with the environment, and it's out of nowhere. So in this scenario, it was pretty evident that this learner was somewhere on autism spectrum. And so what would you do to give the student or resident accommodations in this scenario? This one's very tricky, I know.
Was all your feedback here to this point about just clinical, like, interactions with the team?
It was from all those characteristics, such as nobody cares where you went to school, who your family is, all these things that are brought up, repeating that, talking about one specific drug for an hour, and then trying to apply it 2 hours later was impossible. So there was retention, and then even after developing goals that the individuals made themselves that we agreed on, can't make those goals, such as I'm going to have half the patients worked up by the time we do pre-rounds, and they work up 3 patients out of the 20 because somebody's IV drip of Protonics wasn't appropriate, and so they thought that was the emergency that they had to take care of in the morning. So not realizing what's acute, chronic problems and chasing down things that really had no relevance. We're taking an hour and a half to write a vancomycin notes.
Did this person identify that there was anything wrong?
No. Yep. So then that's the other dilemma. That's the very tricky part of this, is there's not been any disclosure that there should be accommodations or that there's any learning disability or there's been any problems.
Will this impede patient care?
In the long run, yes. As their learner, no. To an extent. We'll get to another scenario with the same situation. So in this scenario, unfortunately, if I had to rank this person, there would be a lot of ones and twos. And that's essentially what happened at the end of the rotation is despite all the feedback, all the goal set, expectations were not met. And despite how big of an effort. Things that were identified was I'm more of a visual and auditory learner, and reading is very, very difficult to retain the information. We implemented those teaching skills, and they still had little impact on. But again, in this situation, the person was very knowledgeable about a lot of things. And so there was definitely a very success in education, but it was hard for them to really learn in the clinical setting. So despite all the feedback, ultimately kind of had to do what you have to do. And that's unfortunate because in this situation, there could be no additional self-awareness built. Sticking with the same thing, which ultimately led to a bigger issue, this comes into what Shelley's asking, does this ever impede patient care? So despite all the issues, you still have to put people in situations where they maybe can grow, learn, and do everything. Specific instructions were given to the resident to carry out a task. A very critical antifungal, I'm not going to give all these details just so we can't identify everything, but a critical antifungal was being initiated in a patient, and they had one peripheral line. And so the resident was charged with observing for anaphylaxis or any type of infusion-related reaction to this antifungal for 30 minutes. And then about 2 hours at the bedside, or it wasn't that long, probably about 30 minutes at the bedside, the drug was there, and it's been compounded and mixed, and it has to be infused within several hours. Well, the residents deemed that this was inappropriate and they needed an additional IV access. I'm the primary preceptor. None of this was ever communicated to me, And so the individual recommended that the nurse contact the physician and get an additional IV access. The nurse didn't really understand what was going on. There was a lot of breakdown in communication, so he contacted the physician, which was a medical resident, and the medical resident said no. Like, we can wait until this other antibiotic finishes infusing. So still wasn't satisfied with that, and then contacted pharmacy that was on call downstairs and wanted them to push the issue. That individual then contacted another preceptor that was involved in the case. And so it happens to be I was sitting beside that preceptor. And so now I'm in the loop. I don't intervene. I actually stay, observe, see what kind of happens and carries on. And so then at 6 o'clock in the evening, after this has been going on for about 2 hours, I go back to the hospital. And then how would you approach the situation now that you're face to face with the resident?
So the patient never received the drug?
At this time, they have not yet. It's not the resident's fault. But I would think most of us would say, the chain of communication was broken down significantly. So what would you do with this resident this time?
He needs to be told, he needs to communicate with you.
That's exactly what I did.
Oh, no.
I am the primary preceptor. That's the first thing I said. Why did you never contact me? I said, you made 4 different phone calls in the span of 10 minutes when all you had to do was get a hold of me. I was in a meeting, yes, at the school, but I told them all the time you can always contact me. So what do you think my observation was? I felt like he was trying to undermine the instructions I gave him. This was difficult because how should I feel? I think I have it on here. Should I be frustrated and angry at this situation?
I don't know if you should, but I would.
I mean, I think everybody would say at this point, absolutely, I would have any right to be very frustrated and angry. And so what kind of crucial conversation should I carry on with this resident this time?
I think you should be honest. I am frustrated and angry at this because, this action made me feel undermined, and this created confusion that translated to a delay in patient care, and, be very clear and concise about, it occurred.
Yes. So this is where instead I did control my emotions. I know it sounds hard to believe, but I did control my emotions, and I said, I am the primary preceptor. There's a major breakdown in communication. You got 3 other people involved. I said, all these people are now confused about what is going on. Do we need additional IV access? And I said, no. But then he told me his side of the story. His side of the story was, well, I know I looked it up, and that drug can only be in that admixture for like 6 hours before it goes bad. Okay. Well, we're only now 2 hours in. We still have 4 hours to go, and the drug's almost done infusing. The other thing is, hey, I got 2 vancomycin notes to do, and I need to go do them. Okay. You could do that at the bedside. But no, we're not in his comfort zone. He wants to go to the library and do them in his peace and quiet. So there's a lot more to the story, but then basically, why did you undermine my authority? Why did you undermine my instructions? Never crossed his mind. That was never the intent of anything. That individual thought they were doing what was best for that patient and for the pharmacy. So that was like the ultimate, clearly there's a big self-awareness problem. Had no awareness of the situation at hand or how others would perceive his actions. So this is, unfortunately, I think, I don't want to say something we may encounter more often, but I think as faculty we could, we have encountered this in classroom settings, and we'll continue to encounter it on rotations. There is something to be mindful of, especially now that when you think about the autism spectrum, they're kind of removing a lot of terms of just like Asperger's. So I had an attending physician that was very open when I was a resident that he had Asperger's. And he was very intent on controlling how he did things, such as if he's at that patient's bedside and that medical chart is not there, get out of the way, because he's going to go crazy. But everybody knew that, so we had to take actions to make sure that didn't happen. But this is something, just because somebody fits on a learning disability or a developmental disability does not mean they cannot actually be achieving individuals. I'll give you in this situation, yes, ultimately the whole program doesn't work out for everybody, but there are still things that people as pharmacists can do, such as research, such as teach, and such as be very accomplished scholars. And that's actually kind of what happens in this scenario. You know, that background information. A lot of individuals in this scenario, they can get fixated on one thing. And if you're doing bench research, you're focused on one thing. And that paper that you write is that one paper at that time. So there are fellowships. There can be other postgraduate opportunities for individuals. So they may not be the most high-achieving individuals on APPEs. You still have to try to develop that self-awareness, but there is going to be a time, and I've dealt with it twice now, that you can't improve the self-awareness because there is a developmental disability that prevents them from making that happening. They just can't do it. And that is a scenario here. So that individual does not belong at the bedside. They don't belong in that critical setting where you have to make rapid decisions. So you direct them into a different path. And that's exactly kind of what happened in this scenario. So to summarize self-awareness, preceptors should be compassionate when addressing deficiencies on self-awareness. You know, I can definitely reflect on this and try to be a little more compassionate about how I direct students improving personal knowledge and abilities and skills. Define those goals at the beginning of rotations that are objective and can be measured and achieved or not achieved, like kind of like a pass-fail on those objectives. Do not dwell on this whole generational issue. We can't fix it. We have to focus on the student that we have right in front of us. Communicate your expectations about knowledge, skills, and their abilities the first day of the learning experience. Setting up those expectations is key. Any questions for me?